Esteemed judges are Dr. Vineet Rehan sir and Dr. Sujala S. Aradhya ma'am.
Good morning, respected judges, faculties, and my dear colleagues. I am here to present my work on Needle fold capillaroscopic pattern in systemic sclerosis, a clinico-capillaroscopic correlation study. Systemic sclerosis is characterized by early and progressive microvascular injury, which occurs prior to cutaneous fibrosis and internal organ involvement. Needle fold capillaroscopy is a simple, non-invasive tool which allows us to assess these microangiopathic changes in the bedside in the outpatient itself. Characteristic scleroderma pattern like early, active and late pattern represent different stages of disease progression. Hence, correlating this clinical finding and capillaroscopic finding aids in assessing disease severity, extent of involvement and disease monitoring. The objective of our study is first to evaluate needle fold capillaroscopic pattern in patients with systemic sclerosis and to correlate these capillaroscopic pattern with clinical disease parameters. This is a cross-sectional observational study with 44 patients of systemic sclerosis diagnosed based on ACR-ULR criteria. Needle fold capillaroscopy was performed using a handheld dermatoscope with 10x magnification. Ultrasound gel was applied to enhance transparency. With around 10 to 15 minutes of stay in room with an ambient temperature of about 20 to 22 degrees centigrade, patient is allowed to sit comfortably with their hands at the level of their heart, and then all the fingers were analyzed. The abnormalities seen in more than 2 fingers were then noted. Capillaroscopic features we assess are capillary dilatation, giant capillaries, microhemorrhages and capillary dropout, and then classified the feature into early, active and late scleroderma pattern. Then clinical assessment was done using modified Rodnan skin score and evaluation for systemic involvement was done. This slide shows spectrum of changes in the needle fold capillary. In the first figure, we can see the relatively the capillary density is well preserved, but there are dilated vessels we can see with which is demarcated with green arrow. In the figure 2, there is dilated capillary, giant capillaries, microhemorrhages, which signifies active pattern of scleroderma. In this slide, we can see there are avascular zone, bushy capillaries, which signify new angiogenesis, and multiple microhemorrhages, which signifies late pattern of scleroderma. In the figure 4, we can see there are tortuous capillaries, meandering vessels, which also signifies new angiogenesis. There are multiple avascular areas also, which is in the late pattern of scleroderma. The baseline demographic and clinical characteristic was the study population is of 44 patients, in which there is a male to female ratio of 1:9. There are 36 patients of diffuse cutaneous systemic sclerosis, while of limited cutaneous systemic sclerosis, there are only 8 patients, which is 18.2% of the study population. Mean disease duration, which we observed, is of 36 months. In our capillaroscopic pattern, there are maximum patient in active pattern, that is 61.4%, followed by early pattern and then late pattern. So active pattern was the most commonly observed pattern in our study. As we go from early to late, there is progressive increase in MRSS, that is mean MRSS in early pattern is only 12, while in that of late pattern it is of 32. Higher systemic involvement, that even we can say that 100% of the patient in the late capillaroscopic pattern have systemic involvement. 92.6% of the patient in active pattern have systemic involvement, and only 20% of patient with early pattern shows systemic involvement. So we can say that Neal fold capillaroscopic pattern reflect progression of microangiopathy in systemic sclerosis. Early pattern were associated with milder disease, and active and late pattern were associated with higher spin score and systemic involvement. To conclude, Neal fold capillaroscopy is a valuable non-invasive tool in systemic sclerosis. Capillaroscopic pattern correlate with disease severity. Neal fold capillaroscopy can aid in disease evaluation and monitoring. To emphasize that video dermoscope is the gold standard for capillaroscopy, but handheld dermatoscope provide us bedside evaluation of capillaroscopy. Limitation of my study is the study design, that is cross-sectional study design, relatively small sample size and lack of longitudinal follow-up. Thank you.
As such, you have pointed out your lacunae. Actually, nail fold capillaroscopy should be done with a video dermatoscope only. है ना?
Yes, we can do with video dermoscope, but it's not readily available. Handheld dermatoscope is cheap. We can use in outpatient also.
Which dermatoscope did you use?
So Dermlight 4.
Dermlight 4. Dermlight 4 video dermatoscopes are easily available. Dynolight in India is very commonly available and is much more cheaper than your handheld. Okay, but otherwise good study. Yeah.
Thank you, sir.
Now I would like to call on stage our next participant, Dr. Rishabh Sangai.
Good morning, respected teachers, judges, and on and all present over here. I am Dr. Rishabh Sangai. I will be presenting a study on nail changes in Hansen disease in tertiary care hospital in Eastern India, a retrospective record-based cross-sectional study. So the background was nail being an integral part of our integumentary system, and it serves as a window to systemic and dermatological diseases. Various pathophysiology exists for nail involvement, like peripheral neuropathy, repeated microtrauma, and vascular impairment in case of Hansen disease. And early recognition of these changes can provide important clues regarding disease chronicity and severity. The rationale was that nail changes in Hansen disease are underreported and there are limited data available in India as well as real world data. So our study actually tried to emphasize on this gap. The aim was to evaluate the nail changes among the patients of Hansen disease, and the primary objective was to determine the prevalence of nail changes as well as to determine the spectrum of nail change abnormalities. And the secondary objective was to look for any association of the nail changes with the spectrum and the type of reaction. So it was a cross-sectional study and done at a tertiary care hospital in Eastern India over 14 months period, and inclusion criteria was age more than 18 years and done in clinically confirmed cases of Hansen, and exclusion was any incomplete case sheet or reports that were not traceable. So we actually took the demographic data into consideration, clinical diagnosis of Hansen disease, symptom duration, as well as the type of lepra reaction, assessed for the slit skin smear of the patient, and outcome variable was the nail assessment of the patient. And appropriate test as per the descriptive statistics, and tests like Shaprovic as for normality and chi-square or Fisher's test were applied. So coming to the results, total 106 subjects were assessed, and the mean age of the population was 36.4 years with a standard deviation of 15.2, comparable means of male and female among the population. And there were 78 males, and with a rural predominant society of 66%. And most of our population were daily wages and the housewives, with 48% and 22%, and the education level was secondary education as well as graduate level of education was seen. Coming to the clinical profile of Hansen disease, 48 patients were in the BT spectrum and 35 patients were of LL spectrum, total 60 patients in the tuberculoid pole and 46 patients in the lepromatous pole, out of which 17 patients were in type 2 lepra reaction and 18 patients were in type 1 lepra reaction. The slit skin smear came like no acid-fast bacilli was seen in 58 patients, and 3 plus AFB was seen in 16 patients. And on the treatment profile, naive patients were 66.1%, and 7.5% were released from treatment. And there were no deformities seen in more than like 3/4 of our population, and hand deformity was the most common among 15.1%. Among the nail changes were seen in 93.4% in Hansen's disease, with only 7 patients having no nail changes, out of which onychomycosis and subungual hyperkeratosis were the predominant features. Infective and neuropathic traumatic changes like longitudinal onychodexis and brachyonychia were also seen. On the nail changes in the tuberculoid pole, 60 patients were onychodexis and onychomycosis were the most prominent finding. In lepromatous pole, subungual hyperkeratosis and onychomedicis were seen. When we try to do a comparison analysis, we have seen like 20 nail dystrophy and subungual hyperkeratosis were significant association in the lepromatous spectrum, and onychomycosis and paronychia, although present in the BT spectrum, did not have any significant association for the tuberculoid pole. These were some of the photographs of onychomycosis, onychodexis, onychogryphosis, and onychomedicis in our patients. 4 of our patients also had 20 nail dystrophy, and with anonychia and brachyonychia seen in the lepromatous pole. And also, as we can see in the lepra reaction side, we have seen like the longitudinal ridging, onychomedicis, and Bu's line were the prominent finding, with significant association among the lepra reactions. And when we tried to do a comparison analysis for type 1 and type 2 lepra reaction, we have only seen like onychomedicis was present in type 2 lepra reaction predominantly. Although type 1 lepra reaction showed longitudinal ridging and onycholysis and Bu's line, but they are not significant association. So for the discussion, our study had almost the similar sample size as per the Indian and the foreign studies. However, nail prevalence changes were higher, and the 20 nail dystrophy and subungual hyperkeratosis were higher in the lepromatous pole. And onychomedicis was seen significantly in type 2 lepra reaction. Unique contribution of our study was like the reaction-wise statistical analysis as well as the pole-wise statistical analysis for the data was done and clinically segregated. So in conclusion, 106 patients were present with 93.4% having nail involvement, 36.4 year of mean age, and most common nail involvement of onychomycosis, subungual hyperkeratosis, paronychia. Spectrum-wise analysis showed tuberculoid pole having infective changes predominantly, with lepromatous pole showing advanced dystrophic changes, and Fisher's extract test also telling that, concluding our study. And longitudinal ridging and where Bu's lines were seen in lepra reaction, with type 1 lepra reaction showing the cell-mediated inflammation, and type 2 lepra reaction showing immune complex-mediated vascular reaction. So these were our limitations of retrospective design, single center study, sample size less, and lack of follow-up.
Kindly highlight what was the inclusion and exclusion criteria.
Ma'am, our inclusion criteria was all patients that are coming to our OPD coming to the OPD with a clinical diagnosis of Hansen's disease, ma'am. So we have included all patients and age of more than 18 years, ma'am.
More than 18 years, okay.
So according to your study, 95% of Hansen patients had nail involvement.
Yes, sir, like 93.4%.
Anything you could find out why the BT patients had more of onychomycosis?
BT patients, sir, mostly like the reason, sir, was not evaluated, but sir, mostly like we can conclude was maybe the poor hygiene that the patients were having and lack of foot care. But sir, like it was also present, sir, in lepromatous pole also, but like the frequency was comparatively less, sir, as observed.
Okay. Thank you so much.
Thank you, Dr. Rishabh. Our next participant is Dr. Shruti Garg, so I'll request her to please be on the dais.
Good morning, respected faculty, judges, and delegates. Today I am going to expand upon my work on clinico-radiological assessment of 110 nail units in nail lichen planus. Today, the diagnosis of nail LP relies heavily on patient history, clinical and onychoscopic evaluation. The gold standard biopsy is an invasive procedure with risks associated with anesthesia, potential downtime, and even scarring. That's where the role of a real-time, non-invasive investigation like ultrasound becomes pertinent. Not only does it invade the nail bed without radiation and contrast exposure, the vascularity assessment with Doppler also helps monitor ongoing inflammation. The primary objective of my study was to assess the frequency of various clinical and ultrasonographic features in nail unit in clinically diagnosed treatment-naive new cases of nail LP. After a detailed history, clinical and onychoscopic examination, severity assessment was done using the NALC score, following which the nails were subjected to nail unit ultrasound. So out of 320 nails that were examined, a subset of 110 nails were subjected to ultrasound examination. The mean NALC score was 4.62. Our data have been tabulated in the slides ahead. So this is a prototype of what we saw in most of our patients. Matrix and bed findings predominated with onychorexis with longitudinal nail bed dyschromia, onychocesia, and onycholysis with subungual hyperkeratosis. As we can see, they can be seen in almost a third of our cases. More advanced cases show longitudinal splitting, anonychia, onychometasis, progressing to irreversible pterygium. Onychoscopy revealed a greater burden of disease compared to clinical examination, highlighting its ability to identify subtle subclinical involvement. As we can see, lamellar splitting, subtle onychocesia, and especially lunar changes which may be missed on clinical examination were well identified by onychoscopy. Longitudinal bed dyschromia and mottled, fuzzy, and distorted luluna are some things which can be missed on clinical examination, picked up well on onychoscopy. The bar chart here shows clinical versus onychoscopic patterns, the left panel showing clinical and the right panel showing onychoscopic features, both showing matrix predominance in nail LP. So was ultrasound able to mirror this evidence? Well, in its own language of black and white, it did. The mean nail plate, bed, and matrix thickness was far more than the normal established ranges, and the peak systolic velocity also exceeded the normal cutoffs. The increased vascularity was seen not only in clinically involved nails, but also clinically apparent looking nails, identifying its sensitivity in subclinical inflammation. The mean values on statistical analysis were showing a p-value of less than 5%, indicating that the changes were not merely due to physiological alteration. The radiograph here shows the nail plate, nail matrix, and nail bed thickness with the measurements noted below. The bar chart here compares the mean nail plate thickness of our patients with the normal range shaded in green. And the box and whisker plot here shows increased nail bed thickness of both the thumb and other fingers in comparison to the established norms. The peak systolic velocity had a vast standard deviation. However, the mean PSP was much greater. And on Doppler, we can see that the vascularity is present in deep and both superficial nail bed and matrix. A unique hypoechoic halo surrounding the origin of the nail plate was identified in a subset of our patients. This finding has not routinely been described in nail ultrasonography before and could potentially be a novel ultrasonographic marker in nail LP. Other ultrasound findings were loss of trilaminar appearance of the nail plate, fragmentation and undulation of the nail plate, and hypoechogenicity of the nail bed and matrix. The arrowhead in the radiograph here shows the hypoechoic halo surrounding the origin of the nail plate, indicating matrix inflammation lifting the nail plate up. This pie chart shows the ultrasound abnormalities distribution. As we can see, the hypoechoic halo sign was seen in about 80.4 patients, only secondary to hypoechogenic nail bed and matrix, which was almost universally present in all the nails examined. So what's new? We could potentially be at the brink of a revolutionary change in how we view the role of radiology as an adjunct to diagnosis and monitoring of nail LP. Not only does it help in objective assessment of nail unit The hypoechoic halo sound in a background of nail matrix changes may serve as a novel imaging marker in nail LP, and the serial nail bed and matrix thickness and peak systolic velocity could serve as a guide to treatment response. The limitations of my study were lack of a histopathological correlation. There was no control group. The ultrasound was performed on a subset of nails, and there always will exist an operator dependency in an investigation like ultrasound, and severity correlation could not be performed. This is also the way ahead and steps that we could further work and do future research in. These were my references. Thank you.
So if you want to continue with this study, what exactly would you want to expand upon? Like you did say there were certain limitations. So what would you want to address?
Ma'am, number one was that a subset of the nails were subjected to ultrasound examination based on which nails were showing clinical features. I would like to do an ultrasound in all of the nails to see if hypoechoic halo sign and other findings are seen universally. Secondly, severity correlation with NALC scores and whether the thickness of hypoechoic halo sign or the matrix and the bed thickness vary with severity or not.
Sure.
With this small study, can you come out with something like we can avoid nail biopsies in this nail lichen planus?
So this is not to say that nail ultrasound can replace the gold standard biopsy, but it might be a bridge between an invasive procedure and clinical and onychoscopic examination alone. With further validation of hypoechoic sign and certain parameters or diagnostic criteria with ultrasound, and with few research, we might be able to be in a position where we can completely do away with biopsy, but not right now.
The only problem is that ultrasound probe is special probe is required, and high resolutions may not be available everywhere. And you need a very trained radiologist who has a eye on catching on nail findings.
Yes.
That is a basic difficulty. Otherwise, glomus tumors and all also are much more sensitive, better than MRI for small
Yes.
glomus also. Thank you, sir.
Thank you, Dr. Shruti. Our next participant is Dr. Sophia Mahin. I would request her to please come on the dais.
Good morning, respected judges. This is Dr. Sophia Mahin before you, and I will be presenting my study on decoding nail psoriasis, onychoscopic patterns, and clinical correlation. Nail psoriasis is a common, underdiagnosed, yet it often precedes or exists independently of the cutaneous disease. Early nail findings are very subtle and often overlooked, but they can have a significant impact on quality of life or may predict more severe disease. So onychoscopy, which is non-invasive expansion of dermoscopy, comes into role by diagnosing those diagnostic clues which are not visible to the naked eye. However, systematic data on early and reproducible onychoscopic features are limited. So we conducted a study to describe and classify the onychoscopic features of nail psoriasis and correlate them with the clinical findings. It was a cross-sectional observational study conducted on 300 clinically diagnosed psoriasis patients for 5 months duration. Amongst these 300 patients, the patients who showed nail pitting, discoloration of nail plate, or nail bed changes were picked. And amongst them, using DermLite DL4 dermoscope, onychoscopy was performed as an adjunctive modality. Patients who were already clinically diagnosed cases of psoriasis. Amongst the most common and specific finding which we observed were the coarse irregular pitting observed in 84.9%. Apart from that, red erythematous nail plate, distal onycholysis with erythematous background, red dotted vessels on hyponychium as well as the nail blade bed, as well as subtle nail fold changes like scaling or capillary vascularity were observed. Now these minimal changes has been seen by clinical, but they cannot be precisely seen, and therefore onychoscopy comes into role. As we can easily see, upon a clinical examination and dermoscopic examination, the results have been greatly varied. While pitting was seen and onycholysis and subungual hyperkeratosis, the specificity which we can observe has been significantly increased, as well as the mean NAPSI scores and mean DAPSI scores shows that onychoscopy as a diagnostic modality can be applied. But as the duration of the psoriasis increased, the resemblance strength of both the diagnostic methods almost approaches. This is a figure of the psoriatic nail showing distal onycholysis with edematous background and superficial fissures. At the adjoining figure, we can see focal crumbling of the nail plate. In the first photograph, we can see there's salmon oil spot present. Apart from that, inflamed nail folds, and absent or damaged cuticle is seen. In the figure beside, we can see subungual hyperkeratosis with splinter hemorrhage. And in the last figure, we can see that the nail appeared almost normal on clinical examination. It was not normal, but almost normal. But upon onychoscopy, we can find fine pitting was present. Onychoscopy can be applied to differentiate between the common mimickers like trichonychia or onychomycosis, where absence of irregular course pitting, oil drop sign, or psoriatic vascular patterns can be seen. Not only individual findings, but pattern combinations are important, because of which we can enhance the diagnostic confidence without resorting to invasive biopsy techniques. In the current study, the age varied from 2 to 65 years, mean being 38.7, and male predominance was seen. This has been in compared to the studies by Yadav and Khopkar and Daulatabad et al. Irregular course pitting was the most common finding, followed by splinter hemorrhage and onycholysis. In 15%, we observed fine pitting. This has not been reported in earlier Indian studies. The limitations of our study that we acknowledge are the restriction of onychoscopy to clinically involved nails and absence of histological correlations. Onychoscopy serves as a practical gap between subtle clinical suspicion and overt clinical diagnosis, and especially it can be helpful in diagnosing early psoriasis. By describing the onychoscopic markers of early psoriasis like nail pitting or minimum vascular changes, our study can reinforce the role of dermoscopy as a non-invasive technique in routine dermatological practice. Onychoscopy does not replace clinical examination, it refines it. These are the references for my study. Thank you.
So for each of the patient, were all the 20 nails examined? Or was it only the nails which had clinical features?
Ma'am, only the clinical features were involved. Actually, we are not doing onychoscopy as a screening modality. We are doing for a confirmatory diagnosis. And we acknowledge this as a limitation that we do not doing it for screening purposes.
Okay. And what was the treatment offered?
The treatment offered was systemic corticosteroids. When systemic involvement was seen as well as for only nail involvement, we prescribed topical tazarotene 0.1%, and in severe cases, even intramatricial injections, corticosteroids were given.
Systemic corticosteroids for nail psoriasis?
No, sir. I meant when ethnoderma patients' early cases came to us.
You said that she's asking nail psoriasis, what treatment did you give?
Sorry, ma'am, I mistook.
Thank you, Dr. Sufia. Our next participant is Dr. Zoya Nasreen. I would request her to please come on the dais.
Good morning to all. My topic is efficacy of infliximab in the nail changes of reactive arthritis, a retrospective observational study. Reactive arthritis is an immune-mediated seronegative spondyloarthropathy which is usually triggered by infections. While joint manifestations are well recognized, mucocutaneous involvement, especially the nail changes, is often under-recognized and frequently misdiagnosed. TNF-alpha plays an important role in its pathogenesis. This provides a strong rationale for the use of infliximab in reactive arthritis. Although infliximab is effective in other spondyloarthropathies, data on its effects on the nail changes in reactive arthritis is limited. Our primary objective was to assess the efficacy of infliximab in the nail manifestations of reactive arthritis using the visual analog scale, and the secondary objective was to analyze the various patterns of nail involvement in reactive arthritis. This study was a retrospective record-based study conducted at a tertiary care center, India, and we included the reactive arthritis patients with the nail involvement treated with infliximab, and the data were collected from the patient records and the pre-filled pro forma containing the demographic details, and the patient with the nail changes attributable to other dermatological or systemic diseases, and those treated with other modalities were excluded, and the included patients received infliximab loading doses at 0 to 6 weeks and followed by a maintenance dose every 8 weeks. And the continuous variables were expressed as mean and standard deviation, and categorical variables were expressed as percentages, and pair t-test was used for the comparison, and p-value less than 0.05 was considered statistically significant. And out of the 39 screened patients, 21 fulfilled the inclusion criteria, and the mean age was around 30 years, and the mean disease duration was around 5 years. And coming to the pattern of nail involvement, we can see the most common pattern was the nail dystrophy and the subangual hyperkeratosis seen in almost 80% of the patients, followed by the onycholysis. And for the assessment tool, visual analog scale was used for the assessment of the severity of the nail involvement, where score 0 represents no symptoms and score 10 represents maximum severity. And assessment was done at the baseline and at 12 weeks after infliximab therapy. Now coming to the results, we found significant reduction in the VAS scores by 12 weeks following infliximab, and all the results were statistically significant with p-values less than 0.001. And this is the baseline picture showing the subangual hyperkeratosis, nail dystrophy, and onycholysis, and at 12 weeks we can see there is significant improvement. Coming to the discussion, our study shows that nail involvement in reactive arthritis is common but frequently under-recognized. The predominant nail findings were onycholysis, nail dystrophy, and subangual hyperkeratosis. And we observed a statistically significant improvement in the nail disease severity following infliximab therapy. This supports the role of TNF-alpha mediated inflammation in the nail pathology. And visual analog scale proved to be a simple and practical tool for the assessing the nail disease in the absence of a validated reactive arthritis nail specific score. Comparison with the other studies, our focus of study was the nail involvement and the response, and the most common nail findings were onycholysis, subangual hyperkeratosis, and dystrophy, and nail severity was assessed using the VAS score, and it was a homogeneous biological study like infliximab was used. And coming to the strengths part, the strengths were the focus on an understudied manifestation, that is the nail involvement, and uniform biological therapy was used, and simple patient-centric outcome measure, that is the VAS score was used. And limitations, it was a retrospective study, small sample size and short follow-up duration, and lack of any objective nail-specific scoring system. Coming to the conclusion, nail involvement is a common but under-recognized manifestation of reactive arthritis and predominantly presents as a nail dystrophy, subangual hyperkeratosis, and onycholysis. Infliximab therapy results in a significant improvement in a nail disease severity within 12 weeks, and nail VAS score is a simple and practical tool for assessing the treatment response in a routine clinical practice.
Is this infliximab available in your institute? That's why
Yes.
you did this. Otherwise, these days, adalimumab and all are quite good for reactive arthritis. Even secukinumab and all. The ease of subcutaneous injection is better than giving IV.
Were all the patients evaluated at each of the intervals when they came back for the therapy? Or was it only beginning of the therapy and end of the therapy?
No, ma'am. In between also they were assessed, ma'am. After
between
every loading doses.
Thank you so much, Dr. Zoya. We'll now begin with the quiz session shortly. And I would like to invite on stage respected Dr. Anupam Das sir for conducting this quiz.
Very good morning, everyone. Without any further delay, we move on to one of the most exciting sessions of any conference, that is the postgraduate quiz. At the outset, my sincere thanks to the organizing and scientific team for having me here to do the quiz. So yesterday we had the preliminary round where I think 14 teams had participated, and from there we selected the top 4 on the basis of an MCQ round. It was a very close finish. There was hardly a difference of 0.5 or 1 marks between all the teams. And the last spot I think was a tie itself, and we had to resort to tiebreaker questions to sort out. Before we start the quiz, I would invite Dr. Mubarak on stage, who will help me with the scoring. Dr. Mubarak, please come on stage. So let's have a big round of applause for the 4 finalists. We have Patna Medical College and Hospital. We have AIIMS Patna, Armed Forces Medical College Pune, and IGIMS Patna. Please come on stage one by one so that we can draw the lots and decide the sitting arrangement. PMCH, please, on stage. Then I would invite AIIMS Patna on stage. Big claps, please. AFMC Pune. Big round of applause. And finally, IGIMS Patna. We don't have? Or we'll call the fifth team. Asha, they are here. Okay. Team D. All right. So all the teams, please introduce yourself. Just check whether the mic is working or not. We start with Team A.
Good morning, everyone. My name is Mishkat Fatma. I am from AIIMS Patna.
Good morning, everyone. My name is Dr. S.S. Biswas, and I'm also representing AIIMS Patna.
Thank you, AIIMS Patna. We come to Team B.
Good morning, everyone. I'm Dr. Jaya Kumari from PMCH Patna.
Good morning, everyone. I am Dr. Neha Nedi from PMCH Patna.
Thank you, PMCH. We come to Team C.
Good morning, everyone. I am Dr. Diksha Garg, Armed Forces Medical College, Pune.
Good morning, everyone. I am Dr. Rahul Nair from AFMC Pune.
Thank you, AFMC Pune. Then we go to Team D.
Good morning, everyone. I am Dr. Nikhil Sharma from IGIMS Patna.
Good morning, everyone. My name is Dr. Shivani Kumari from IGIMS Patna.
Okay. Welcome, everyone on stage. Now, before we start the quiz, let me explain the rules to you. We'll not follow the conventional format. We'll do the quiz on infinite bounds format. I'll explain. So there will be 32 questions. Each correct answer will carry 10 points. There is no negative marking. Format of the quiz, I'll explain. Suppose one question goes to Team A. Team A gives the correct answer. They get plus 10. Simple. Suppose Team A gives a wrong answer. There is no negative point. There is no negative marking throughout the quiz. Suppose Team A gives a wrong answer or they pass the question. It goes to Team B. Team B, suppose they give the correct answer. They get plus 10 again. So even a past question gets you plus 10. Right? Now, suppose A, B, C, D. The question keeps on passing from say A to D. Nobody gives the correct answer. Question goes to the audience. They give correct or incorrect answer. Doesn't matter. Now, since that particular question was not correctly answered by anyone, for the next question, we will start with the next team. Suppose for the first question, the first chance was given to Team A. Since nobody answered, for the next question, the cycle will start from Team B, because now Team B should get the first chance to answer. Is this clear? Any doubt? There is no negative marking. The best thing about this format is, what happens is in many quizzes, suppose there is an apparently a weak team is seated right to you, so you get more and more passed on questions, so that gives an undue advantages to, to the team which is sitting and apparently to a weaker team. So this happens in the conventional format. In this format, what happens is at the end of the quiz, the team which answers the maximum number of questions correctly, they win the quiz. Because even a past question will give you full marks. So, and another thing is reversal of rounds is also not required. That is again very important. But what is very important is the quizmaster's jobs become very difficult. Okay. So unless I ask you to answer a question, please don't answer. Because suppose we start with Team C gives wrong answer, we go to Team D. So when I say Team D, please answer, then only you answer. Otherwise, if anyone answers out of turn, it becomes a chaos and the question gets disqualified. Clear? So 32 questions, we will follow this format. Once this format is completed, then we will go for a super over where I'll explain the rules to you. All right? And this is the most important disclaimer for any quiz, right? So for the next 40 to 45 minutes, the quiz master is always right. That is rule number 1. In case you have read something else in your books, in your seminars, in your journals, doesn't matter, you need to go back to rule 1 again. Okay, you can abuse me, you can do whatever you want, but after the quiz. During the quiz, there is no scope of any argument or any question, all right?
And most importantly, I'm not here to test your knowledge. It's just a fun experience. Because suppose you ask me a set of 32 questions, it is highly possible I may not be able to answer a single question correctly. It always happens. So there is nothing to feel tensed at all. So all the teams ready? And please discuss amongst yourselves and then answer. Please don't give multiple answers because that will create a chaos. And discuss amongst yourselves, be clear, be loud on the mic so that there is no confusion. All right? And give only one answer. Don't give multiple answers. We start with team A, that is AIIMS Patna, right? A is AIIMS, B is PMCH, C is AFMC, D is IGIMS. Okay. We start with team A. Team A ready? Look at the nails. You need to tell me what is the most likely cutaneous finding in this patient. Or I would say which skin disease he must be most likely having. I think the photograph on the bottom is very clear. Diagnosis of the skin disease, not the nail finding. What skin disease he might be having? No, yeah. Water. Yes.
Nail lichen planus.
We go to team PMCH. Team AFMC.
The image is not clearly visible.
थोड़ा आगे करवाइए तो इसको आगे या ऊपर रखो ना ये थोड़ी देर के लिए ऊपर कर दो ना इसको उठा के हाँ
Team B, you need to answer immediately.
So the most likely finding is psoriasis.
Team AFMC?
So alopecia areata.
Excellent answering. What's the nail finding here?
Tracheonychia.
I would go for Scotch plate nails. You can see those pits arranged vertically and horizontally in a very geometric fashion. Yes, this is Scotch plate nails and I was looking for the answer alopecia areata. So team C gets plus 10. AFMC Pune gets plus 10. Good answering. Now since this was answered by team C, we now move on to team D. Ready? A simple one coming up for you. This gentleman is considered the grandfather of European onychology. He is credited with descriptions of numerous nail conditions like your onychopapilloma, onychomatricoma, bidet nail, and nail degloving syndrome. Who is this legendary onychologist? Very, very famous. Plenty of clues are there. Team D. Pass. Team A.
Dr. Robert Barrow.
Very good answering. This is Dr. Robert Barron. He is considered the grandfather of European onychology. Team A gets plus 10. Claps for Team A. We now move on to Team B. Ready? Okay. Read the question carefully. This is a very specific nail finding for this disease. Proximal thin and soft triangular nail bordered by a thick and rigid distal nail plate. This is the classical description of the nail finding which you get here. Other findings include intestinal polyposis, alopecia, and abnormal nail pigmentation. Abnormal skin pigmentation. What is the diagnosis? This is a syndrome. You have intestinal polyps, you have alopecia, you have abnormal skin pigmentation in the form of dyschromatosis.
Sir, it is Peutz-Jeghers syndrome?
Team Pune. There is no negative marking, you should try.
Sir, Cronkite-Canada syndrome.
Excellent answering. This is Cronkite-Canada syndrome. Good answering by Team Pune. Team Pune gets plus 10 again. Right? Okay. Now we go to Team D. You have to give me the complete diagnosis. I think the findings are very clear. He's an 83-year-old male, non-smoker, presenting with chronic purulent cough. There is lower limb lymphedema bilaterally. Findings on CT, you can see severe bilateral cystic bronchiectasis. What is the
Yellow nail syndrome?
Very good answer. This is yellow nail syndrome. This was a simple one. Team D gets plus 10. Big claps for Team D. This is yellow nail syndrome. All right. Now we go to Team A. Team A ready? Very simple one coming up. No clues. Give me the diagnosis. So everyone is whispering to each other. This seems a very simple one. Team A, Team A. There is no negative marking. We go to Team B.
Dyskeratosis.
Team B.
Pachyonychia congenital.
This is Pachyonychia congenital. Simple one. Can you explain the findings?
So there is nail dystrophy along with palmoplantar keratosis and mucosal involvement.
Yes, this is Pachyonychia congenital. Team B, that is PMCH, gets plus 10. All right? Now we go to Team Pune. Ready? You have to tell me the diagnosis. There is congenital onychodystrophy, there is anonychia, there is fifth finger brachydactyly, there is digitalization of the thumb, hypoplastic distal phalanges, but everything else is normal. Hair, teeth, and sweat glands are normal. What is the syndrome? Team Pune.
Sir, is it Clauston syndrome?
No. We go to Team IGIMS, that is Team D. Team A. Team B. Okay, we go to the audience now. I had picked this up from one of the articles published in IJPD. So, Dr. Shvetlina is smiling. All right, this was a tough one. This is Cook syndrome. All right, autosomal dominant ectodermal dysplasia. Someone mentioned one type of ectodermal dysplasia. I think I cannot give it to you. Sorry, okay, I wanted the specific answer. This is Cook syndrome. No problem. Now we go to Team D. Since the previous cycle started with Team C, now we go to Team D. Team D ready? It's a simple one. There are multiple images. You need to connect and give me the complete diagnosis. Team D. What is the diagnosis? There are two names, any one would do. There's something on the skin, on the legs, on the nails, of course, and on the mucosa as well.
On the nails, splinter hemorrhages.
I want to know the complete diagnosis, not individual findings. Team D. Okay, we move on to team A. B. Finally, team C.
Is it Wegener's?
Very good answering. This is Wegener's granulomatosis. Can you explain the findings?
Sir, pyoderma gangrenosum, splinter hemorrhages,
Okay.
strawberry gingivitis is actually there.
I'll give it to you. Ulceration on the leg, the tongue, you see subungual digital infarcts, and of course you can also see small vessel vasculitis. Okay. This is Wegener's granulomatosis. Granulomatosis with polyangiitis is the other name. Very good answering. Team C gets plus 10. We start with team D again. What is the diagnosis? You can see the clinical image, you can see the onychoscopy. What is the diagnosis?
Onychomatricoma.
Very good answering. This is onychomatricoma. Can you explain the finding on the right hand side?
Sir, woodworm appearance.
Honeycomb appearance. Yes, this is onychomatricoma. Good answering by team D. They get plus 10. All right. Simple one coming up. We go to team A now. Team A ready? What is the drug I am talking of?
Phenytoin.
Team B.
Amrolofin.
What?
Amrolofin.
Team C.
Sir, cyclosporin.
Yes, this is cyclosporin. Can you connect the images? The first one is the
source.
Source.
And gingival hyperplasia,
Yes.
the chemical structure, and use in
Psoriasis. Yes. Good answering. This is cyclosporin. Team C again gets plus 10. So first image shows the source. The second one shows the chemical structure. Then you see it's used in psoriasis and of course the gum hyperplasia. Good answering by team C. This is cyclosporin. Team C gets plus 10. We go to team D now. Okay. Again, you have to identify the drug. Now, long back, in an attempt to identify the cause of pellagra, this person, Bartolomeo Gosio, he isolated Penicillium glaucum, a fungus from a mold growing on a spoiled maize. Later, this product was used as an immunosuppressant in transplant surgery by non-competitive inhibition of an enzyme. So the clues are: it is isolated from Penicillium glaucum, it is an immunosuppressant, it is used in transplant surgery, and it is inhibiting an enzyme. What is the drug? Team.
Tacrolimus?
We go to team A. Team
Sirolimus.
B. Team C. No? Yes, Dr. Shwetalina gets plus 10 points. This is mycophenolate mofetil. The clue was Penicillium glaucum and transplant surgery. All right, nobody gets this. So big claps for Dr. Shwetalina. She gets plus 10 and not a single team gets it. No problem. So this was mycophenolate mofetil. So I think the cycle will now start with team A. Okay. A long question is coming up. Take your time to answer. Team A. Now this is a matrix tumor of the nail bed, which typically presents with pachymelanonychia. Right? Pachymelanonychia, this is a term which reflects dual finding of nail thickening and pigmentation. Now this tumor can also manifest without pigmentation, and it has three histopathological variants. One is your acanthotic, one is your papillomatous, one is your keratogenous. What is the name of this tumor? Team A. If you go to team, yes, you want to answer?
Onychopapilloma.
Team B. C. Wait, team B, yes.
Onychocytic matrixoma.
I'll give it to you. The question was about to get passed. This is, can you repeat your answer loudly?
Onychocytic matrixoma.
Onychocytic matrixoma. Yes, this is a recent and rarely described tumor arising from the nail matrix epithelium. So team B gets plus 10. Very good answering. Team B gets plus 10. We now go to team C. Ready? Simple one coming up. Especially if you're coming to ONYCHOCON, you must have read this. So, team C. A drug for onychomycosis. So they're already ready, approved by US FDA in July 2014. It inhibits an essential fungal enzyme, leucyl T-RNA synthetase. Team C.
Tavaborol.
Very good answering. This is tavaborol. Team C gets plus 10. Claps for team C. This is tavaborol. Okay. Can we have a look at the scores now? Yeah. Okay. So, okay. Team A, AIIMS Patna is at 10 points. Team B, PMCH Patna, and Team D, IGMS Patna, both at 20 points. And Team C, FMC Pune leading with 50 points. Claps for all the 4 teams. Going good. Now we will start with Team D. Very simple one coming. This is probably the easiest question of the set. This is simple. You just have to name the sign. Team D. This is Samit sign. Okay, and what is the finding shown here?
Cuticle.
Ragged cuticle, yes. Team D gets plus 10. IGMS Patna, Team D gets plus 10. Big claps for Team D. All right. We now come to Team A. Okay. After a simple one, a different kind of thing. You have to identify the connecting link between the photographs. Don't tell me all are men or something like that, please. Okay. Something is common between all of them. Yes?
Nail surgery.
No. We go to Team B. C.
So the first image is Robert Neeson.
Okay.
So something related to phototherapy, sir?
No.
Lupus vulgaris.
Yeah, that is fine, but who are the other two? No? Team D?
Something related to capillaroscopy.
No. Question passes to audience. Okay. All of them are Nobel Prize in Medicine winners. First one is Niels Ryberg-Finsen, who was awarded the Nobel Prize in 1903 for, as you mentioned, using phototherapy in lupus vulgaris. And the later two persons, Dr. Ardem and Dr. David, they were jointly awarded the Nobel Prize in Physiology of Medicine for their discoveries of receptors for temperature and touch. No problem. Nobody gets this. So now the cycle will start from Team B. Team B ready? Ready? Okay. Simple one coming up. What is the condition? Look at the index fingers very carefully. You have to mention the diagnosis. This is present since birth. There is no progression. This is asymptomatic. Look at the index fingers on both sides. I have put an arrow, a pointed triangle. What is the diagnosis? Team B. Pass? Okay. We go to Team C.
So COIF, congenital onychodystrophy of index finger, Aiso-Kikuchi syndrome.
Aiso-Kikuchi syndrome. Very good answering. This is Aiso-Kikuchi syndrome. Excellent answering by Team C. Congenital onychodysplasia of index fingers. This was identified long back in 1969. Okay. So Team C gets plus 10. Now we go to Team D. Okay. There are two parts. You have to answer both. This is a diagnostic technique originally involving the use of a 3 mm punch through a softened nail lesion, followed by the application of a hemoccult stick. And this has been recently modified to utilize hydrogen peroxide. What is the name of this technique and what is its primary indication? There are two parts. Team D. Dr. Vishal is there in the audience, Vishal Gaurav. Okay. He gave me the idea of this question during dinner and I loved that and I put this in the question. I hope he was there.
No idea.
No? Pass. Pass. Team A.
Haneke's technique.
Good answering. This is the Haneke's technique. And what is the, I cannot give it to you. Okay. I'll give it to you. It is used to differentiate between subungual hematoma and subungual pigmentation. So this is Haneke's technique. Thank you, Dr. Vishal, for this question. So Team A gets plus 10. You get full points. Claps for Team A. We now go to Team B. Team B ready? Okay. So the next question also I was discussing with Vishal, but this was already there in my PPT. So Team B. Presence of multiple polydactylous onychopapillomas in adults is a significant marker of which syndrome? Team B. This is one of the recently described things. So, pass. We go to Team C.
Sir, is it incontinentia pigmentae?
I couldn't hear you.
Incontinentia pigmentae?
No, no, no. Team D. Pass. Team A. Okay. Audience? Yes, your good name, please. Dr. Ananya. Big claps for Dr. Ananya. This is BAP1 tumor predisposition syndrome. It is an inherited condition that significantly increases the risk of developing several types of cancer, like your uveal melanoma, cutaneous melanoma, BCC, renal cell carcinoma, mesothelioma, and of course, when it comes to nail, multiple onychopapillomas. So, thank you, Dr. Ananya. All right. So, we will now start with Team C. Ready? What is the only FDA approved treatment for brittle nails? It's a topical solution containing something. I want that full name. Team C. I have taken this question from Oncycology textbook, edited by Chandar ma'am. So, Team C.
Tazorotein, sir.
Team D. Team A. Team B.
So vitamin E.
Yes?
Vitamin E.
No, no. So it's a topical solution containing 16% polyurea urethane. So I took this from the textbook. So no problem. This was a tough one. No problem. So nobody gets this. Now we go to Team D. Team D ready? Simple one coming up. This is a very typical nail change which has been described in Kawasaki's disease, hemophagocytic lymphohistiocytosis, and systemic arthritis. What is the nail change I have shown here? Something very classical is visible on the left side. We come to team A.
Half and half nail.
Team B.
Splinter hemorrhage.
Team C.
Sir, periangual desquamation.
No. Audience? Very good answering. Your good name, please? Dr. Sumit. Big claps for Dr. Sumit. This is orange-brown chromonychia. This is orange-brown chromonychia. Okay. So nobody gets this. We again start with team A now. Okay. Team A. Team A ready? You have to tell me what is onychodacnomania. Team A.
Habit of continuously biting nails.
Let me see if I get a better answer. Team B.
Sir, habit of biting nails for lustful pleasure.
Team C.
Same thing, sir. Habit of biting nails till the point of lustful pleasure.
Team D. Same answer. Ideally, we cannot give it to anyone, but this was the complete answer I was looking for. Patient bites the fingernails between his teeth, extremely painful, psychiatric resort. I think I'll give it to team B. They were the closest. You mentioned about that till the point of pleasure, right? Okay, I'll give it to team B. Team B gets plus 10. This is onychodacnomania. All right. Team B gets plus 10. So scores team A, AIIMS Patna is at 20 points. Big claps for team A. Team B, PMCH Patna and IGIMS Patna team D, both at 30 points. And team C, that is AFMC Pune, leading with 60 points. All right. We will now start with team C. We start with team C. Cathepsin C mutation, palmoplantar keratoderma, periodontitis, onychogryphosis, arachnodactyly, acroosteolysis. What is the syndrome?
Haim-Monk.
Very good answer. This was a simple one. This is Haim-Monk syndrome. Team C gets plus 10 again. Big claps for team C. Okay. Again a simple one coming for team D. What is the maximum possible total score in NAPSI? Maximum possible pass. Team A.
60.
60? No. Team B.
Sir, total score in APSI is 160.
This is 160. 8 for each nail, so 20 nails, 160. This is 160. All right. So team B, PMCH gets plus 10 again. Okay. We go to team C. Look at the image very carefully. Look at the nail and look at the skin also. All right? What is the diagnosis? Look at the nail and also the skin.
Lichen striatus.
Very good. This is nail lichen striatus. Good answering. Team C gets plus 10 again. This is nail lichen striatus. Not nail, there is findings on the skin also. There are nail changes as well. So, team C gets plus 10. We go to team D now. There's a bulla, all right? A hemorrhagic bulla, I can tell you. The lesion was incised, drained, blood-tinged purulent fluid came out. The biopsy revealed spongiosis with plenty of neutrophils. What is the most likely diagnosis? And the patient responded very well to penicillin group of antibiotics. So that is the clue. What is the diagnosis? Team D.
Dactylitis, acute perineum.
Team A.
Sweet syndrome.
Team B. Team C.
Syphilitic dactylitis.
No. Audience? Yes, your good name, please. Yes? Jayashri? Chaya, okay. Big claps for Dr. Chaya. This is blistering distal dactylitis. All right, so nobody gets this. So we will now start with team A again. It's a tough one coming up. Team A. It's a rare birth defect, mainly affecting the big toe, where the nail fold grows too much, partially covering the nail, often causing paronychia. Look at both the great toes. This is present since birth. Very rare. What is the most likely diagnosis? Team A. Okay. No? Team B? No?
Sir, Cornelia de Lange syndrome.
Team C?
Sir, congenital malalignment of great toe.
No. Team D? I was trying to remember. ये वही था, ये अलग है. Okay. Okay. Team D?
Congenital malalignment of hallux.
This is congenital hypertrophy of the lateral nail folds. I cannot give it to anyone. Whatever Dr. Mubarak is repeatedly telling, जो दिख रहा है वही answer है. Congenital hypertrophy of the lateral nail folds. Okay, this is very rare. No problem. Team, nobody gets this. This is congenital hypertrophy of the lateral nail folds. This is very rare. The image is self-speaking, right? All right. Now we go to team B. Right now? Yeah, team B. Simple one. This is a frequent cause of allergic contact dermatitis to nail polish. This is the chemical structure. Of course, the structure will not help you. What is the molecule?
Sir, tolusabutamide, formaldehyde. Sir.
Yes?
Tolusabutamide. Sir, I'm confusing. Formaldehyde kind of allergy.
This is like a tongue twister. Okay, team C?
Sir, toluene sulfonamide formaldehyde.
Yes?
Tosilamide formaldehyde resin.
I'll give it to you. This is tosilamide formaldehyde. Yes, this is tosilamide formaldehyde. Team B, I was not very clear on what you were telling. So I'll give it to team C only. This is tosilamide. No, we'll give it to them because there was an answer. Team C gets plus 10. Tosilamide formaldehyde resin. Plus 10. All right. Team C gets plus 10. Now we go to team D. Okay. Again, drugs. This is a very new, I don't think it's available yet, triazole antifungal agent, primarily used in Japan for onychomycosis. The standard regimen is 100 milligram once daily for 12 weeks, not yet approved by in US, but it was approved in Japan in 2018 for onychomycosis. And now it is being studied for eumycetoma as well. I'm talking of an azole. What is the name of that azole? Team D. It's a big name. So, no? Team A? B? C?
Osaconazole.
No? You go to the audience? Yes. Okay, so Dr. Ananya and of course Chandar ma'am, Shikha ma'am, everyone get plus 10. This is fosravuconazole. This is something very new and one of the upcoming molecules. This is fosravuconazole. Nobody gets this. So we will now, I forgot the cycle. We start with team A now. Yes, team A. Can you see anything on the left side? Mostly no. But on the right hand side is a ultraviolet light dermoscopy, and you can see a pink thing which is glowing. What is the diagnosis?
Glomus tumor.
Very good. This is a glomus tumor. Good answering by team A. Team A AIIMS Patna get plus 10. This is the pink glow, a new sign for diagnosis of glomus tumor on ultraviolet light dermoscopy. Big claps for team A. Okay. We go to team B now. This is my case only, which got published in the recent issue of John's. Thank you, ma'am, for accepting this. And what is the diagnosis? Team B. The hard copy of the journal is available here and there. So whenever you find a journal, go through it. Team B.
Exostosis.
Yes?
Exostosis.
Okay, I'll give it to you. This is subungual exostosis. Team B gets plus 10. Good answering by team B. Yes.
I just wanted to use this opportunity because Dr. Anupam has asked the question. This journal, the third issue of John's, is available for all the delegates. Please collect it from this topic stall before leaving. Carry on.
Thank you, ma'am. So team B gets plus 10, right? This was subungual exostosis. Okay. We go to team C now. What is the FDA approved biologic specifically for nail psoriasis? Specifically for nail psoriasis, team C.
So bimekizumab.
Team D. Team A.
Etanercept.
Team B.
So infliximab.
Audience. I was looking for adalimumab, which gained FDA approval in 2017 specifically for fingernail psoriasis. Okay, nobody gets this. Fine, no problem. This is adalimumab. And we now go to team... फिर से भूल गया. Team D. Okay. We go to team D. Okay. Team D. You love wearing nail polish? No. Okay, so this question is for team D only. Let me finish reading. Phthalates, especially dibutyl phthalate, that they have been historically used in nail polish as plasticizers, all right, to prevent chipping and cracking. But concerns over reproductive and developmental toxicity have led many brands to remove them. Now almost all the nail polishes are labeled as 3 free. So what are the 3 ingredients we are talking of? Nail polish ideally don't have these 3 ingredients because they are considered to be toxic. What are those 3 ingredients? This is a tough one. Team D. No. Team A. Team B. Team C. Okay. Audience? No. I would acknowledge Dr. Soumya Jagdishan for this. We asked this question in another quiz. It went unanswered. 3 free is dibutyl phthalate, toluene, and formaldehyde. All right. This is a 3 free nail polish. No problem. Nobody gets this. We will now start with Team A. Last one. Simple one. Team A, ready? You have to identify this gentleman. His name is linked to several systemic illness, psychological stress, typhoid fever, chemotherapy. He was a French physician. He is also famous for his investigations of physiology of the heart and lungs. Very important name when it comes to
Vidal.
yes?
Vidal.
No. Team B? C?
Joseph Simon Bow.
Very good answering. This is Joseph Honor Simon Bew. This is Bew. Team C gets plus 10. All right. Okay. We will need one piece of paper for all the 4 teams for the next round. Char paper. Before we move on to the next round, we will have the scores. Team AIIMS Patna and IGIMS Patna both at 30 points. एक page सबको दे दो. Team, big claps for Team A and Team D, please. Team PMCH Patna at 50 points. And Team AFMC Pune leading with 100 points. Claps for Team C. Okay. So not to worry, we have the super over left. Things can change in this particular round. I'll explain to you. In this particular round, you're not supposed to answer anything on mic. Okay? You have to just write your answer on the paper. Don't answer anything on mic. We'll need 4 pens also. So, there are 3 questions. Just listen carefully once you are settled. Please do not answer on mic. That is the most important thing. And here we have a lot of negative marking, so be careful. So, let me explain. There are 3 questions, right? For every question, there are 3 clues. Say for the first question, if you answer correctly, you get, for the first question, for the first clue, if you answer correctly, you get plus 30. If you give a wrong answer, you get minus 15. 1-5. If you answer in the second clue, you get plus 20 or minus 10. If you answer in the third clue, you get plus 10 or minus 5. Okay? So things can change in this round. Now there are a few queries. Yes. Yeah. One more thing. Suppose, yes. Yeah. That is understood. Yeah. Let me finish. So, suppose you give a correct answer in the first clue itself. It's not that you are eligible for the subsequent clues also. You are out. Suppose you give a wrong answer for one clue, you are still eligible for the subsequent clues. You can keep on trying. Suppose, say Team C, you give wrong answer for the first clue. You get minus 15. Second clue, you give correct answer. You get plus 20. So if you once you give the correct answer, you are out. But if you give a wrong answer, you can continue. Is this clear? So don't answer on mic. Please write on the paper. If there is any, any confusion, the question gets disqualified. Any doubt, ask me now. Yes? No? Ready? Okay. So question number 1, first clue. The first description of this disease in the modern sense is attributed to Cornelius Celsus, the Roman philosopher, who described a disease which was treated with tar and sulfur. The name of this disease was first introduced by Galen to describe an itchy exfoliative condition of the eyelids and scrotum, which was managed with a viper's broth. Which disease I am talking of? If you are sure, you can answer plus 30 or you can go to the next clue. Nobody wants to take a risk. If nobody is ready, then I'll go to the next clue. No? Tease, koi le lo. Nahin. Nobody is taking. Okay. Next clue. In 1910, a German physician described a severe form of this disease, a generalized form of this disease, which is accompanied by hypocalcemia and high fever. Plus 20, minus 10. Nobody wants to take the risk again. Team B wants to answer. Please write on the paper. Don't answer on mic, just write on the paper. ले लो, ले लो. Keep it with you. Team B gets plus 20. Big claps for Team B, they get plus 20. We go to the last clue. Simple one. This is the evolution of treatment for this condition. You need to write on the paper, yes. Team A gets plus 10. Big claps for Team A. B is done. C ने क्या बोला? Team C and Team D gets plus 10. Team B gets plus 20. एक ही बार, yeah. A, C and D get plus 10. सबको plus 10. Yes. So I was talking of psoriasis. Some of them answer pustular psoriasis. Okay, I'll give it to you. This was psoriasis. So team B gets plus 20, A, C and D get plus 10. So as of now, the scores are team A is at 40, team B is at 70, team C is at 110, team D is at 40. Big claps for all the 4 teams. Let's move on to the next question, the first clue. Ready? All right. This condition is named after 2 American pediatricians who jointly published the first description of this disorder in the American Journal of Diseases of Children in 1922. Plus 30 minus 15. Everyone wants to play safe. C is playing very safe. Like we are leading, हम शांत बैठे रहते हैं, risk लेना ही नहीं है. Okay. I think B, A and D you should try because it will give you. No? Okay, I'm going to the next clue then. Now you will be able to answer. This was published in JID in 2000 and the diagnosis is there in the name of the article, so I have blocked that. Bastuji Garin, doesn't that ring? Of course you know this. No? Okay, team A is trying. Yes, team A, please fold your answer sheet, fold it. Team A gets plus 20. Claps for team A. They have got the correct answer. That is plus 20. B, C, D, nobody's trying? Okay. Okay, B is also trying. Don't answer on mic. Team B. You have to write. क्या? We cannot give so much time. I'll go to the next clue then. D is also answering. Okay. Team B and Team D, again they get plus 20. Team C is not trying. All right, we move to the last clue. This is a severe cutaneous adverse reaction. Only C can answer now. Cyclosporin has emerged as a drug of choice for this life-threatening condition. Team C. If you want to answer, you can just You can speak on mic, yeah.
SJS, sir.
Yes, this is Stevens-Johnson syndrome. I think here was the clue, Bastuji Garin, right? So, no problem. Team A, B and D, they get plus 20 and team C gets plus 10. Big claps for all the 4 teams. This is Stevens-Johnson syndrome. We come to the last question of the quiz. I think team A is at 60, team B is at 90, team C is at 120, and team D is at 60. So now the catch is, PMCH Patna is at 90, AFMC Pune is at 120. So PMCH has to answer in the first clue. So the pressure is on team B. And if B answers, C definitely has to answer. Okay, ready? Third question, first clue. It's a tough one. The condition was known since ancient times, but often mistaken for genetic issues or aging. In 1853, a German medical student, George Meissner, first described its etiology, drew its clinical appearance, and used sodium hydroxide for examination. What is the condition I am talking of? If PMCH is answering, AFMC has to answer. Else everyone can sit quiet. A and D, of course, you can answer. You have to write on paper, yes? Yes, of course. B, you are not answering? Too much of pressure, okay. We go to next clue. All right. Next one is very obvious. We go to the next clue. I think you will answer now. A very typical pattern on onychoscopy. I think C has answered. Team C gets plus 20. Big claps for Team C. I think they are the winners. Team A gets plus 20. Team D gets minus 10. Team B is not answering. We go to the last clue. So I think we are done. 10% efinaconazole is FDA approved for treating mild to moderate cases of this disease. Team B and Team D, please, okay, but only Team B can answer. Yeah? Right? Team B gets plus 10. We were talking of onychomycosis. All right, and this is, pattern is known as? Yes, aurora borealis pattern. So, correct. So, I would acknowledge, of course, Dr. Vishal, Dr. Bhaskar, John's textbook, John's journal, textbook of onychology, from where I picked up 2-3 questions, and of course, other journals as well. I would thank the organizing and scientific team again for having me here. Heartiest congratulations to all the 4 teams and everyone who participated in the prelims. The team which finishes on the 4th position is IGIMS Patna. Big claps for Team D. They finish on 50 points. 3rd position, Team A, AIIMS Patna. Big claps for Team A as well. Team B and Team C, they were quite close. Team B finishes on 100 points. PMCH Patna. And the winners of ONYCHOCON 2025 quiz are the participants from Armed Forces Medical College, Pune. Big claps for them with 140 points. Big round of applause for all the 4 teams. Thank you, Dr. Mubarak, for helping me with the scoring, and thank you everyone for your attention. Hope you enjoyed the quiz. See you soon again. Thank you. Over to the organizers now. I think prizes and all will be distributed in the valedictory. Okay. So whatever prizes are there, you can now be running after Dr. Shiparna. Okay. Thank you so much. Thank you. I think we can have a group photograph and then we can reassemble.
A very warm thank you to our esteemed quiz master for conducting such a crisp, engaging and intellectually stimulating quiz. I would now request Dr. Mrityunjay Kumar sir and Dr. Arup De Sarkar sir to please come on the dais and chair the next session.
Hello. I now invite Dr. Tulika Rai to present the session on the topic treatment of nail psoriasis, both topical and systemic. Dr. Tulika Rai, please.
Presentation is not loaded. Where is my presentation? It's not. Good morning, everyone. So in the next 10-15 minutes, we'll be talking about the treatment of nail psoriasis. Nail involvement is common in psoriasis with a documented prevalence of 10 to 18% and an estimated lifetime incidence of 80 to 90%. Isolated nail psoriasis is present in only 5 to 10% of the patients. Nail matrix inflammation is characterized by nail pitting, red spots in the lunula, leukonychia, and crumbling. Nail pitting is the most common finding in nail psoriasis, and it reflects the duration of the disease. With intermediate and ventral nail matrix involvement, the nail can present with red spots in the lunula and the leuconychia. Long-term severe involvement of the entire nail matrix causes a nail plate to become crumbly. The nail bed involvement causes oil drop patches, onycholysis, subungual hyperkeratosis, and splinter hemorrhages. The nail psoriasis severity index is an objective tool which is most frequently used to evaluate the severity of nail psoriasis based on the extent of involvement and location in the nail unit. And in most of the studies, NAPSI has been used to measure the severity of the disease. The nail is divided into 4 quadrants, and the presence of any manifestation in the nail matrix and nail bed is described above and is evaluated. Each nail has a matrix score of 0 to 4 and a nail bed score of 0 to 4. So the maximum score is 8 for the fingernails, for each fingernail and toenail. Strong consensus that few nail disease should be identified as nail psoriasis affecting 3 nails, and that a NAPSI of less than 20 indicates mild disease. Nail psoriasis severity scale is used to define nail psoriasis as minimal, mild, moderate, and severe in different studies. There are few things which should be told to the patient. Nails should be kept short and protected from injury. Habitual biting and potential of tazarotene ointment in nail psoriasis. Under study on 46 patients where the nail psoriasis was treated with tazarotene cream 0.1% versus clobetasol propionate 0.05% cream. It was a double-blind study, and improvement was seen in both the arms after 12 weeks. Under double-blind RCT for 12 weeks on 36 patients where topical tazarotene 0.1% cream with topical clobetasol 0.05% cream in chronic plaque psoriasis. It was a double-blind randomized right-left comparison study. Topical tazarotene was less effective as compared to the steroid cream. Under study on 37 patients were randomized to treatment with methotrexate, initial dose 15 mg per week, or cyclosporin, initial dose 5 mg per kg body weight for 24 weeks. The primary outcome was the NAPSI. In this study, the oral treatment was used. Moderate effectiveness on psoriatic nail was found in the 2 treatment agents, and there was no difference in efficacy between the 2 groups. Under study on 36 patients, where 36 patients with moderate to severe nail psoriasis were treated with acitratine in the dose of 0.2 to 0.3 mg per kg per day for 6 months. And they found good results. And the low-dose acitratine therapy shows NAPSI score reductions comparable with those studies evaluating biologic drugs for the nail psoriasis. Multiple studies are available showing the efficacy of the biologic agents in the management of nail psoriasis. Adalimumab for nail psoriasis, efficacy and safety from the first 26 weeks of a phase 3 randomized placebo-controlled trial. Patients were randomized 1:1 to 40 mg adalimumab every other week or placebo. So in most of the studies, the drugs were compared with the placebo on biologics. Adalimumab improves signs and symptoms of moderate to severe nail psoriasis as compared to the placebo arm. Under study on 302 patients with nail psoriasis, express phase 3 RCT patients, where infliximab induction and maintenance therapy was given for moderate to severe psoriasis, and what they found that it was effective as compared to placebo. Under study on 367 patients with nail psoriasis, evaluation of improvement in skin and nail psoriasis in bio-naive patients with active psoriatic arthritis treated with golimumab results through week 52 of the Go Vibrant study. Again, the drug was superior to the placebo. Even multiple studies are there where tofacitinib has been used and has been found to be efficacious in the management of nail psoriasis. Efficacy of tofacitinib for the treatment of nail psoriasis, 2 52-week randomized control phase 3 studies in patients with moderate to severe plaque psoriasis. Patients were randomized 2:1 to receive placebo either 5 mg per day, tofacitinib 10 mg, or placebo arm twice daily. At week 16, placebo-treated patients were again randomized to tofacitinib, and improvement was seen in nail psoriasis in the tofacitinib arm. Apremilast, an oral phosphodiesterase 4 inhibitor, has also been found to be efficacious in the management of nail psoriasis. The studies that are available are ESTEEM 1 and ESTEEM 2. These are trials, randomized to receive apremilast 30 milligram twice daily or placebo. Apremilast reduces the severity of nail and scalp psoriasis. So summarizing it, we have the evidence from the Cochrane review, 18 randomized controlled trials which involved 1 to 6 participants and were mostly based on a single study per treatment. 10 studies assessed the topical treatments applied to the surface of the skin like clobetasol, cyclosporin in maize oil, hyaluronic acid with chondroitin sulfate, 5-fluorouracil, or a combination of diethrenol with salicylic and UVB, tazarotene and calcipotriol. 5 studies assessing the systemic treatments. 3 studies assessed the radiotherapy. In 5 studies, significant improvement of nail psoriasis compared to placebo with infliximab, golimumab, superficial radiotherapy, electron beam, and the Granz rays. Powerful systemic treatments have been shown to be beneficial, but we have to see whether it is just the nail psoriasis or there is systemic involvement. So for the severe disease, we can use the systemic treatment. Otherwise, just for the isolated nail psoriasis, we should start with the topical treatment. So the evidence for the use of topical treatments is inconclusive and of poor quality. However, this does not imply that they do not work. Topical treatment options could be beneficial and need to be further investigated. So we still need better studies to conclude what would be the best treatment option for the nail psoriasis. So we can take up any question if there are any questions. Thank you.
Any questions from audience? No. Okay, thank you, Dr. Tulika.
Thank you so much, ma'am, for such an enlightening session. I would now request the speaker and chairpersons to please receive their memento. We'll now move forward with the thesis award session, and the judges for the session will be respected Dr. S. Sachidanand sir, Dr. Ghazal Ahmed ma'am, and Dr. Gaurav Das sir. The first participant is Dr. Chaya Shri. I would request her to please come on the dais.
Okay.
Good morning, everyone. I would like to start my discussion with a simple question. Have you ever wondered the pigmented nails is simple or so serious? Myself, Chayashri S. I am going to present my study on evaluation of clinical, etiological and dermoscopic features of melanonychia involving 2,400 nails. This was a cross-sectional study conducted on 120 patients involving 2,400 nails. The aim of the study was to evaluate clinical, dermoscopic and etiological features of melanonychia and to correlate etiology with clinical and dermoscopic features. Here 120 melanonychia patients underwent detailed clinical and dermoscopic evaluation. KOH, nail clippings, culture, B12 levels and nail matrix biopsy were done wherever required to confirm the etiology. The mean age of the study was 34.5 years with predominantly males. The onset was predominantly gradual. The most common color noted was brown, followed by gray, followed by black, and the most common pattern noted was longitudinal, followed by diffuse, followed by transverse. Melanonychia was noted in 25% of the patients. Band homogeneity, longitudinal ridges, this was seen in majority of the patients, which tells that melanonychia is predominantly benign. And other nail plate changes like thickening, nail plate dystrophy, hemorrhage, satellite globules was noted in a few patients. Nail matrix was predominantly normal. Pitting, lunula involvement and augmentation of pits was noted in a few. Similarly, nail bed, it's predominantly normal. Onycholysis and subungual hyperkeratosis was noted in a few. Dermoscopy highlights subtle nail abnormalities such as border regularity, band homogeneity, color variation, structural changes. It remains useful for clarifying ambiguous signs like pseudo-Hutchison sign. These are the representative clinical and dermoscopic features of causes of melanonychia. In the first image, we can see multiple nail involvement, usually thumb and index finger, with grayish longitudinal bands. Dermoscopy showing homogeneous brown or gray background with parallel longitudinal lines with uniform spacing. This is racial melanonychia. In the next image, 1 to 2 nails with diffuse multicolor pigmentation with distal onycholysis, subungual hyperkeratosis. Dermoscopy showing irregular non-parallel lines, jagged spikes at the distal edges, yellow-white streaks, no lines of parallelism. This is fungal melanonychia. In the next image, single nail involvement with longitudinal band of 3 to 5 mm, dermoscopy showing uniform regular parallel longitudinal lines which are consistent in color, thickness and spacing. This is melanonychia secondary to nevus. In the next image, multiple nail involvement with diffuse brownish pigmentation with nail ridging, tracheonychia, nail plate dystrophy, dermoscopy showing gray-brown homogeneous background with thin longitudinal lines with surface roughness, ridging, reduced linear visibility, dull or opaque nail plate reflection. This is nail lichen planus. In the next image, multiple nail involvement with longitudinal brown band with onycholysis, subungual hyperkeratosis, dermoscopy showing irregular brown longitudinal lines with splinter hemorrhages, red dots in the lunula and onycholysis. A novel finding in a UV dermoscopy, that is augmentation of pit. This is melanonychia secondary to nail psoriasis. In the next image, we can see multiple nails with brown transverse pigmentation, dermoscopy showing regular uniform transverse bands, occurs weeks to months after starting the drug. This is drug-induced melanonychia, and the drugs we found out in the study was cyclophosphamide, cytosine and daunorubicin. In the next image, we can see single nail involvement with black variegated appearance with Hutchison sign nail dystrophy. In the dermoscopy, we can see color variations, border irregularity, extension of pigment to lateral and proximal nail fold with triangular sign, nail plate dystrophy. This is melanoma. In the next image, we can see grade 2 pigmentation, brownish diffuse color, which was associated with history of trauma. Dermoscopy showing peripheral red blood globules, clear proximal margin, no lines of parallelism. This is subungual hematoma. Coming to melanonychia mascaradis, in this image we can see there is a pigmentation of the proximal nail fold. Extension of pigment to the proximal nail fold will think of Hutchison sign melanoma, but in the KOH, fungal colonies are seen. This is fungal melanonychia showing Hutchison sign, and this tells the importance of basic investigations like KOH in case of melanonychia. In the next image also we can see there is extension of pigment to proximal nail fold. But on the dermoscopy, the pigmentation was seen under the transparent cuticle. This is pseudo-Hutchinson sign. Even the nail plate was also normal. This is nevus showing a pseudo-Hutchinson sign. In the next image, grade 2 pigmentation will usually think of fungus, but on the dermoscopy, we can see red blood dots and the globules. Even on the nail plate biopsy, it showed the hemorrhages. This is subungual hemorrhage mimicking as fungal. Next, longitudinal melanonychia in case of fungus. Longitudinal melanonychia in case of isolated nail psoriasis. KVH was positive in 67% of the patient. Fungal culture predominantly showed Trichophyton species followed by Aspergillus niger and fumigatus. Nail biopsy results was predominantly fungus followed by nevus, psoriasis and melanoma. Not all brown is fungal, not all black is melanoma. It has a wide spectrum of causes that demands clinical, dermoscopic and laboratory correlation. These are the wide variety of causes what we have found out in the study. While racial and fungal melanonychia predominates, inflammatory, systemic, nutritional causes form a significant subset. Melanoma, though rare, it remains the most critical diagnosis to exclude. Racial melanonychia is the most common thing, so symmetrical bands in darker skin should never be over-investigated. Infections, nevi, trauma often mimic one another, so dermoscopy and labs are very essential. Inflammatory and nutritional causes highlights the need to consider matrix inflammation and deficiencies. Drug, habit, exogenous pigment causes are significant, making thorough history taking is important. Melanoma is rare, but irregular lines and periangle spread must trigger early biopsy consideration. Melanonychia is not a color diagnosis, it's a pattern diagnosis guided by clinical and dermoscopy. Thank you.
How was your sample size calculated? You have done
So one study was there. In that, prevalence was around 12%. From that, we have calculated the sample size.
Yeah, that you could have included here only.
Okay.
What is the method of calculation? Any idea? Sample size? This is which type of study you are presenting?
Cross-sectional observational study, sir.
Any idea over sample size?
So based on the prevalence rate, we have calculated.
But you should have mentioned it.
Okay, sir.
What is the most common cause for melanonychia?
Sir, in my study, it was a racial followed by fungal, sir.
What is the characteristic of drug-induced melanonychia?
So drug-induced melanonychia in my study, it was usually presented with transverse brown homogeneous bands, sir. Usually weeks to months after starting the drug.
You have done dermoscopy.
Yes, ma'am.
Right. I just want to know the definition of globules. You mentioned globules. When do we call it globules? When dots, when clots?
Ma'am, in my sense, dots are a very minute thing compared to the globules, around 0.5 mm. And globules are larger compared to dots.
There's a definition for this.
Definition, size, I don't know.
Okay.
Thank you, Dr. Chaya. I would now request Dr. Tanveed Kaur Makar to please come on the dais for the next presentation.
Good morning. My title was Association of Nail Changes with Peripheral Arterial Disease in Geriatric Population. So the nail changes are highly prevalent in elderly, involving at least single nail with 80 to 90% of the population. Mostly they are asymptomatic, and the peripheral arterial disease was also commonly seen in elderly with prevalence of 20 to 30%. So the peripheral arterial disease causes reduced peripheral perfusion, which may influence nail plate integrity and nail fold microcirculation. The link was proposed between the impaired blood flow and the nail structural changes, including the capillary abnormalities. So, however, no prior study was evaluated the association between the PAD and nail changes in elderly. So, understanding this may provide a simple, non-invasive indicator of peripheral vascular compromise. On seeing the architectural changes in the peripheral artery, there is microcirculation changes which can cause tissue adaptation and remodeling, which can further cause severity of the symptoms such as rest pain, fatigue, chronic pain, chronic non-healing ulcer, gangrene, or amputation. So the lacuna that we found in literature was, there were many studies exploring the systemic diseases, however, no study has been found evaluating peripheral arterial disease and the nail alteration, and there was limited data on the tonal capillaroscopy, as well as there was no age-specific capillaroscopic reference available for the values of elderly. So our aim was to evaluate the nail changes in the geriatric population and correlate with the presence of peripheral arterial disease. Our primary objective was to evaluate the association, if any, between the nail changes and the ABPI, as well as to assess the clinical etiological profile of the nail changes, to evaluate the onychoscopic features of the nail changes, and to evaluate NFC changes in the geriatric patients. It was a pilot study with a minimum sample size of 100, and we included all geriatric patients with age more than 60 years, involving any number of nail changes. We took patients of more than 60 years, and we took total of 115 patients. We did a detailed examination, and we performed mean ABPI using handheld Doppler. And the clinical and onychoscopic features were seen in all 20 nails, and NFC was done on 4th and 5th fingernail and 1st and 2nd toenail. Then the notable findings in our study was, it was the common age group was 65 years. The most common risk factor was the sedentary lifestyle. The most common pre-existing disease was dermatophytosis, and the pre-existing comorbidity found was diabetes mellitus, and the symptoms of PVD was commonly reported was fatigue followed by pain during activity. The notable other findings were, the signs of PVD was pedal edema, which was commonly reported. The abnormal ABPI was seen in approximately 38% of population, and normal was seen in 61.6% of the patients. The total number of fingernails that NFC could be evaluated was 112, and the total number of toenails that could be done were 101. And the mean capillary density was fingernails was 6.75 capillaries per millimeter, and toenails was 4.8 capillaries per millimeter. So we could find the significant agreement between the dilatation, tortuosity, capillary dropouts, as well as neoangiogenesis when comparing the fingernails as well as the toenails. And these are the findings of fingernails, where we could see the mean capillary density. The second image is showing the capillary dilatation and the giant capillaries, the meandering and the tortuous capillaries seen in the third figure. The fourth figure is showing the buddy capillaries, microhemorrhages, and the capillary dilatation. In the fifth figure, we can see the microhemorrhages, and in the sixth figure, we can see the subpapillary plexus, as well as in the fifth image, it is seeing avascular areas. The NFC changes of the toenails that were showing were capillary dilatation, as well as the avascular area and tortuosity, meandering capillaries, and the microhemorrhages and avascular area that were noted in the toenail changes. The mean capillary density was significantly associated with the abnormal ABPI seen in toenails. And the common physiological changes that we could see were onychorexis, onychochesia, Bio's line, and onycholysis. In case of pathological findings, we can see onychomycosis was most commonly reported, followed by chronic paronychia, nail psoriasis, post-traumatic changes, and the nail lichen planus. The abnormal ABPI was only significantly associated with the onychomycosis, and the positive microscopy features of dermatophytosis was seen in, the positive microscopy was seen in 58.87% patients. And the fungal growth was reported in 49.5% of patients, and dermatophytes was the most common. Dermatophytes was the most commonly reported finding, that was showing 48.1% population, with trichophyton and tagrophytes were the commonly reported etiology. Then on comparative analysis of the nail changes of clinical and onychoscopic features, the significant agreement was seen in onychochesia, pitting, as well as the splinter hemorrhages, onycholysis, and the scaling of both lateral nail fold and the proximal nail fold. These are the findings showing clinical images showing the onychorexis involving all nails, the tenting of the nail plate with the distal onycholysis, and nail plate thinning with longitudinal ridging and discoloration, the diffuse melanechia, the megaluna, the chronic paronychia with xanthocrea, and the onycholysis with subungual hyperkeratosis and yellow discoloration multiple fingernails and toenails. The onychoscopic images showing a transfer fibrillar onycholysis with onychochezia, the longitudinal melanechia, the Biot's line and the transverse fibrillar onycholysis, the longitudinal ridging, the yellow discoloration with onycholysis, the coarse irregular pitting, as well as the longitudinal ridging and splitting and pterygium. So in our study, the toenail changes were most frequently seen as compared to the fingernails with common involvement of the great toenails. The total nail dystrophy, the pencil nail and the clubbing were the common morphological changes. On onychoscopic finding, the significantly higher frequencies were reported of onychochezia, pitting, onycholysis, splinter hemorrhages as well as scaling. The toenail NFC showed lower capillary density as compared to the fingernails, and the toe capillary density was significantly associated with abnormal ABPI. The nail changes in elderly, the pathologically were more commonly reported as compared to the physiological changes, and the most common reported was the onychomycosis followed by the chronic paronychia, the nail psoriasis and post-traumatic nail dystrophy. The common physiological changes that we could see were onychorexis, onychochezia, Biot's line and transfer fibrillar onycholysis. And the abnormal ABPI showed significant association with onychomycosis. So the limitation in our study was the small sample size. There was no standard protocol for the toe NFC. There were many confounders in our study such as systematic disease, autoimmune disease and dermatological conditions. And we recommend a multicentric study with a larger sample size that may reflect the population profile more reliably. These were my references. Thank you.
So what was your conclusion of the study?
So that, as we all know, that the nail can act as a window for the systemic diseases. So in our study,
one-line answer.
Okay, so the abnormal ABPI was significantly associated with the onychomycosis and the toenail mean capillary density. So we should evaluate these things in our daily day-to-day practice for considering peripheral arterial disease as a surrogate marker.
The ABPI is significant associated with onychomycosis. What does it indicate?
So that it can act as a surrogate marker, that if you are evaluating a patient who is coming to us with onychomycosis and he's an elderly patient, we can ask for the symptoms of any PVD if the patient is having, and then we can further refer the patient for evaluation of the peripheral vascular diseases.
It is directly related to that. It can be an incidental finding.
Sir, for that was, we had a smaller sample size. For that, we need a larger sample size.
So we say, like you also described, P value is less than this. It is significant. What is the meaning of P?
What is the meaning of?
P.
So that will be the type of the study, the type of the errors that we expect, that the significant association will be, P value suggests the significant association and the alpha type error.
What is P? P is something.
Ma'am, the statistical significant value.
It stands for? P stands for?
Thank you.
Now I would like to request Dr. Shivani ma'am and Dr. Aditi Snehal ma'am to kindly join the dais to chair the next session.
So I would like to call Dr. Mubarak, the most dynamic and omnipresent in every conference, managing everything, to present the next session.
Good morning, everyone. Good morning, respected chairpersons. With the permission of the respected chairperson, I would like to begin my talk. I have been given the topic of pediatric nail disorders. So I will just keep it short, give a brief introduction about various pediatric nail disorders and its significance, and I will discuss a few common clinical cases. So why does pediatric nail disorders matter to us? So as we all have been going through that nail is a very important diagnostic window. Like it is one of the, sometimes it is the only clue to various systemic and genetic diseases that we are going through. And the normal pediatric nail is not similar to adult nail. It is a more soft, fragile, and hence it is always predisposed to various minor traumas and assaults, which leads to various nail changes, which may not be pathological at all. At one hand, there is risk of over-investigation, going for unnecessary biopsies or interventions, and on the other hand, there is risk of missing various serious illnesses, congenital deformities, and associated syndromes with them. Also, in children, we face significant diagnostic challenges due to limited cooperation from the child and obviously the anxious parents. Now coming to nail unit anatomy, I think we have already had enough of it in the last 2 days. So nail development, it starts from 12th week and continues to 25th week, which gives a plausible reason why most of the congenital nail disorders, they are present by birth. As I have told in the previous slide, the nail at birth is thinner and softer, so there are many physiological and developmental variations. The growth rate of nail peaks at 10 to 14 years, which correlates with the normal hormonal growth spurts. Now coming to the normal variants and various physiological changes. Regarding the shape, there can be significant variation in the shape of the nail plate, with the oval nail being the most common, the trapezoid toenail also being common. These are just benign things. We need not go for any investigation or treatment. The normal nail width, finger width ratio is 0.7. If it is less than 0.5, we consider it micronychia. If it is greater than 0.8, we consider it macronychia. Now, another condition, cholanonychia, which is associated with iron deficiency anemia in adults. In the great toe of neonates and infants, it is often idiopathic. It needs no treatment and no iron profile workup is needed for it. It resolves as the nail plate thickens. Similarly, leukonychia in children. It occurs due to minor occasional trauma to the nail matrix. That there are punctate transverse forms that are all associated with this trauma only. And any white spot in the nail that is moving anteriorly as the nail plate is growing, I think reassurance is the only treatment. The other benign neonatal findings are transient periungual pigmentation, more common in the pigmented skin types. Then second one, as I have shown in the image, it was also present in the quiz today, congenital hypertrophy of lateral nail fold. Then chevron or herringbone nails, that occurs, that is an inverted V-shaped appearance of the nail plate due to the germinal matrix proliferation patterns. Now coming to the cases, this is my first case. It was a 7-year-old female. She presented with continuous thickening and deformation of the fingernails and toenails that had been present for 6 months. The patient had developed erythema and scales on her scalp, auspicious sign was positive. So clearly it was a case of nail psoriasis. If matrix is involved, we get the findings like nail pitting, leukonychia, red spots in the lunula, and nail plate crumbling. If the nail bed is involved, we get onycholysis, subungual hyperkeratosis, oil drop, splinter hemorrhages. This was the second case, a 4-year-old male with thickening and deformation of the fingernails. Multiple fingernails on both hands were rough, deformed with hyperkeratosis, with erythema around left thumb nail which showed desquamation. So it is important to know that nail changes may precede the cutaneous psoriasis and also a marker or predictor of underlying psoriatic joint disorders. Although benign, nail psoriasis can cause functional impairment, cosmetic concern, and the patient is having higher risk of developing psoriatic arthritis. Both these cases were treated with intralesional secukinumab injections. The needle was inserted from the two sides as shown in the image on the proximal nail fold at 2 mm distance at 2 points, as well as on the both sides of anterior nail plate. 30 mg secukinumab was injected into each nail, a total of 150 mg for each hand. The patient were injected once every 2 weeks for 3 months, and then it was changed to subcutaneous injection of 150 mg once a month for 9 months. A significant reduction in NAPSI was observed over 12 years. The improvement was significant as shown in the images. This is the exhaustive list of various treatment options that we have for management of nail psoriasis. Now coming to the second case, a school-going male child presented with progressive nail discoloration and dystrophy involving both fingernails and toenails for past 8 to 10 months. The condition started insidiously and gradually progressed to involve all 20 nails. There were no skin lesions. There was involvement of multiple nail with rough and thin dystrophic nail plate and distal splitting, suggestive of nail matrix damage. On onychoscopy, a pigmented fibrotic band extending distally from the proximal nail fold with loss of normal proximal nail sulcus indicative of nail matrix scarring. There was proximal tapering and thinning of the nail plate with longitudinal splitting of the lateral nail plate remnants consistent with evolving nail pterygium. So a diagnosis of isolated nail LP with multi-nail involvement was made. Nail involvement occurs in 1 to 10% of LP cases. Pediatric nail LP is often under-recognized. There is male predominance reported in pediatric cases. If there is nail matrix involvement, we most commonly get longitudinal ridging, nail plate thinning, fissuring, onychorexis-like splitting, rough dull nail surface, progressive nail plate narrowing, and dorsal pterygium formation. If there is nail bed involvement, there is subungual hyperkeratosis, onycholysis, nail plate discoloration, distal nail plate crumbling. In advanced stages, there is nail pterygium, which is pathognomic. There is partial or complete anonychia and permanent nail loss. Coming to treatment, if it is an early or mild disease where only few nails are involved, we give high-potency topical corticosteroids applied to proximal nail fold, and tacrolimus and pimecrolimus can be used for maintenance. For progressive disease, where multiple nails are involved, there is worsening dystrophy or early pterygium, we give intralesional triamcinolone acetonide 2.5 to 5 mg per ml into proximal nail folds repeated every 4 to 6 weeks. For severe or refractory cases, systemic therapy, where oral corticosteroids, methotrexate are preferred options. Coming to the third case, a 7-year-old female with gradually progressive distal nail yellow-whitish discoloration of the index finger, subungual hyperkeratosis, onycholysis. On examination, cuticle was intact with mild periungual scaling. The nail plate was opaque, rough, and irregular. The nail scrape treated with 20% potassium hydroxide revealed presence of yeast cells with round, oval, and budding shapes. The findings were consistent with distal subungual onychomycosis. These are the four most commonly identified patterns. The most common one is distal subungual lateral onychomycosis. There is yellow-white discoloration starting at the distal free edge with subungual hyperkeratosis, onycholysis, nail plate thickening, and crumbling. The second one is white superficial onychomycosis, where we get chalky white patches on nail surface. The nail plate is soft and friable. The third one is proximal subungual onychomycosis, whitish discoloration near the proximal nail fold seen in immunocompromised children. And the last one is total dystrophic and onychomycosis. These are the typical dermoscopy findings of onychomycosis, where we get jagged proximal edge of onycholysis. There are longitudinal spikes. I think this question was also there in quiz. There is a ruin appearance and subungual hyperkeratosis with color variegations. Regarding treatment options, the topical treatment is indicated for mild disease where there are less than 3 nails involved, less than 50% of nail is involved, and when no matrix is involved. The topical agents are amrolfine 5% nail laca, cyclopirox 8% laca, efinaconazole 10% solution, and tavaborole 5% solution. Coming to the last case, a 60-year-old right-hand dominant boy presented with a painful progressive non-traumatic deformity of his left thumbnail. The patient's mother reported a 3-year history of significant tenderness of the left thumb upon contact or compression. The examination revealed a mass deep to the nail plate in the central third of the proximal nail. X-ray of the left thumb revealed an indentation of the dorsal cortex of the distal phalanx. So a clinical diagnosis of glomus tumor was made. A glomus tumor, a rare benign vascular neoplasm arising from the glomus body, which is meant for thermoregulation. They are concentrated in the subungual regions of the fingertips. These tumors account for about 2% of all hand tumors, usually present as small solitary subungual or periungual nodules. There is a classical triad of paroxysmal pain, pinpoint tenderness, and cold hypersensitivity. The clinical tests such as Love's sign, Hildreth test, and cold sensitivity can aid in diagnosis. MRI angiogram is the investigation of choice, and complete surgical excision is the cure. These are the intraoperative images of the patient where left thumb plate has been removed and the tumor has been excised. At 1 year follow-up, the patient's nail revealed regrowth of a normal nail. The patient also reported resolution of the preoperative symptoms of pain and tenderness. Thank you, everyone. Thank you for listening.
Any questions from audience?
Thank you, ma'am.
Any questions? Thank you, Dr. Mubarak, for one nice presentation.
Thank you.
Thank you, Dr. Mubarak, sir, for such a nice presentation. I would request the speaker and chairpersons to kindly receive their memento. I would now like to request respected Dr. P.P. Prabhakar sir and Dr. Punkesh sir to kindly come on the dais and chair the next session. I request Dr. Punkesh sir to kindly chair the next session. I would request Dr. Vishal Gaurav sir to please chair the next session along with Dr. P.P. Prabhakar sir.
Good morning, doctors. Now session presented by Dr. Rajneesh Kumar, a renowned dermatologist. He explained the approach to paronychia. Dr. Rajneesh, come on the desk.
Good morning to one and all. Thank you, sir, for the kind words. Myself, Dr. Rajneesh Kumar, and I will be speaking on approach to a case of paronychia. Starting with the introduction, as we all know, that paronychia is inflammation involving lateral and nail folds. It presents clinically as inflammation, swelling, and abscess formation. Females are most commonly affected, and the fingernail being the most commonly affected than the toenails. Sahab mentioned. Now, classification, depending upon the duration, if the duration of disease is less than 6 weeks, we call it acute paronychia, while if the duration is more than 6 weeks, we call it paronychia. Coming to acute paronychia, it is the bacterial infection that gains access to the perionychum through the compromised epithelium. The common etiology include the Staph aureus, Streptococcus pyogenes, Pseudomonas, and Escherichia coli. Coming to the clinical features, there is a rapid onset of painful erythema, swelling of the lateral and or proximal nail folds. The onset of the disease is around 2 to 5 days after minor local trauma. A superficial abscess is usually frequently present. The infection usually extend along the proximal nail fold to the opposite side of the nail that we call the run around infection. This is a clinical photograph of acute paronychia. In this you can see the abscess is clearly seen. Complications, phelon, that is the infection of the pulp of distal phalanx, osteomyelitis, onychomatosis, that is the nail plate develops a deep transverse groove with subsequent separation of distal nail plate, onychodystrophic, and ischemic necrosis of the fingertips. These are the complications of acute paronychia. Coming to the differential diagnosis, again phelon, the infection of the distal phalanx, proximal onychomycosis, and trauma. These are the differentials. Diagnosis is mainly clinical. There is a digital pressure test. This is performed by asking the patient to oppose the thumb and index finger, which shows blanching of the skin overlying the abscess cavity. Zinc smear can also be done. KOH mount is useful to differentiating bacterial from non-bacterial paronychia. Pulse culture is indicated when there is an abscess to guide the antimicrobial therapy. Coming to the treatment options, the topical antibiotic play an important role in this. Mupirocin and fusidic acid are commonly used. And among the oral antibiotics, amoxicillin with clavulanic acid, cefixime, and in cases of MRSA infection, linezolid and clindamycin. Surgical treatment is also done. If there is abscess, we do the incision and drainage. And if this ingrowing is also associated, then partial or total nail avulsion is also done. Coming to the chronic paronychia. Chronic paronychia is rather an inflammatory dermatosis involving the nail folds, and it is clinically characterized by hypertrophy of proximal or lateral nail folds. There is absence of cuticle. There is progressive retraction of proximal nail folds. It is an inflammatory response to repeated exposure to irritants or allergens. Etiology-wise, Candida albicans is the most commonly involved pathogen in chronic paronychia. Colonization of bacteria, especially anaerobe, is thought to be a secondary occurrence. Triggers: exposure to environmental irritants and irritants like wet work, food, chemical. Patients who are atopic or have psoriasis or patients with allergic contact dermatitis are more prone to develop. Patients on medications like retinoids, protease inhibitors, and epidermal growth factor inhibitors, those patients who are on such type of medication are also likely to develop chronic paronychia. This is the flow chart of clinical features, that is edema and mild edema of proximal lateral nail folds with a loss of cuticle. Nail becomes hypertrophic with marked retraction of proximal areas. The dystrophic nail changes are almost always associated. The important ones, ridging and bew lines, are commonly seen. Differential diagnoses include the proximal subungual onychomycosis, onychomycosis caused by non-dermatophyte moles, squamous cell carcinoma, and Bowen disease. Diagnosis is again clinical, that is characterized by hypertrophy and retraction of proximal nail folds, loss of cuticle, and nail dystrophy. There is a history of repeated exposure to irritants or allergen is usually present. Patch test is indicated if there is suspected case of allergic contact dermatitis. Culture is done. In this, there is a mixture of gram-positive, gram-negative, and anaerobic organism is seen. And a skin biopsy is indicated when we suspect of a malignancy. Treatment options: first of all, the most important is the counseling, that is general measure and precaution. Avoidance of the environment trigger allergen. Patients should be advised to keep their hands as dry as possible and use protective gloves whenever needed. Antibiotic during the episodes of acute paronychia. Role of antifungals, both topical and systemic. Combination of antifungal and topical steroid topical as well as intralesional triamcinolone acetonide in the dose of 2.5 mg per ml is indicated. Now, summarizing, paronychia is the most common infection affecting nail folds. It most commonly affects females, especially who are having works with excess water exposure. And in occupational and environmental allergens, pain and swelling abscess is usually present in acute cases. Topical and systemic antibiotic are needed in acute cases, while antifungal and steroids, both topical and intralesional, are useful for chronic cases. Thank you.
Any question from audience? Nice presentation, Dr. Thank you.
Thank you, sir. Thank you.
Thank you so much, the speakers and chairpersons. I request them to kindly receive their memento. I would now like to request Dr. R.R. Madhukar sir and Dr. Kunal Sinha sir to kindly join us on the dais and chair the next session.
Good morning, everyone. I would request Dr. Vineet Rehlan to kindly come up and give his talk on surgical management of paronychia.
Good morning to all of you. And my job has been made very easier by Dr. Rajneesh. He has covered the theoretical part of paronychia. So I'll be covering mainly about the chronic paronychia part, so where surgery has a very important role. I bring greetings from Nail Society of India. So these are very, these are very common conditions. If you see this type of nail, you have a very common condition of swelling and swelling of the nail folds with edema and nail dystrophy taking up. So by definition, as Dr. Rajneesh has said, that it is inflammation of the nail fold. If it is less than 6 weeks, it is acute paronychia. And if it is more than 6 weeks, it is chronic paronychia. So the common etiology for chronic paronychia is occupational exposure. So homemakers, bartenders, dishwashers, these are common people who get chronic paronychia. Other causes could be infection, tumors, drugs like retinoids, epidermal growth factor inhibitors, protease inhibitors can also cause chronic as well as acute paronychia, more commonly acute paronychia. So this is a classical picture of chronic paronychia. You can find there are nail folds are inflamed, they are indurated, rounded up, and the cuticle is lost. So main pathology is the cuticle is lost. So what is the pathogenesis? It was earlier thought to be infective, but these days, as Dr. Rajneesh covered, it is a type of hand dermatitis caused by environmental exposure. Candida, which is often isolated, is mainly due to a secondary colonization only. So there are various grades of chronic paronychia. I won't cover that. The main pathology which comes up is this. Actually, there is a multifactorial etiology, irritant contact dermatitis with physical trauma to the cuticle. So cuticle is lost. So once the cuticle is lost, all the irritants and extravia will get colonized in the sac below the cuticle. So this will lead to repeated inflammation. And this repeated inflammation causes the nail folds to round it up and retract, further exposing the nail grooves. And this leads to recurrent infections. Then there's a stage which comes that the nail folds become fibrous, so the topical medications are not working in that cases. So the main medical treatment for chronic paronychia is topical steroids, sometimes interlesional corticosteroids, and tacrolimus are also very effective. So most important treatment is preventive measures. You avoid chronic prolonged exposure to contact irritants, avoid trimming of cuticles, finger sucking, use rubber gloves, apply regular moisturizers. Now coming on to the surgical treatment, it is reserved for only the recalcitrant cases. If suppose you have treated the patient for around 6 months, they are not responding, go for 6 months, the surgical treatment. What is the rationale of surgical treatment is that the chronically inflamed and fibrosed proximal nail fold loses its vascular supply. So the topical drugs are not able to penetrate and systemic drugs cannot be delivered to area of decreased vascular supply. So various surgical techniques are there, en bloc excision with nail plate avulsion, Swiss roll technique and square flap technique. So before you attempt a surgery, please take a detailed history, do a lot of examinations, do KOH, gram staining, fungal and bacterial cultures. And this is a pre-operative assessment as for all nail surgeries. Take a detailed history, rule out, take a history of peripheral vascular disease, bleeding disorders, cardiovascular disease. Then if the patient is on ecosprin, you have to think about stopping it for 3 to 5 days before surgery, but I don't stop it. It's a very minor surgery. History of any discontinued smoking prior to surgery, get X-ray, ultrasound or MRI of the digit before attempting surgery, do HIV test, hematological test, and antibiotic prophylaxis. And most important, detailed informed consent has to be taken. So coming on to the first surgery, this is called en-bloc excision, and it's a very, very simple surgery. So this is the nail where we are going to do the surgery. So what do you have to do? You have to first give as for all nail surgeries, give a proximal digital block on both sides of the nail, inject 1 ml of lignocaine or with adrenaline you can give. Wait for 5 to 7 minutes, 10 minutes till the action of the local anesthetic take place. Put up a tourniquet, exsanguate and tourniquet. So anesthesia, tourniquet, exsanguation, then mark the surgical incision site. So this is a crescent. So it starts from the lateral nail fold extending onto the proximal nail fold like this. So this is a maximum, this would be 2 to 3 millimeter. So full en-bloc excision of the proximal nail fold. So first you separate the nail plate from the nail fold by inserting a nail spatula. This is a nail spatula, and give an incision on this. So this takes out the proximal as well as the adjoining nail fold. So this is a crescent which has taken out, and leave this for healing by secondary intention. So this is the result after 4 months. So you saw this nail we have operated, and this is after 4 months. How beautifully the nail fold has come back, as well as the cuticle. So this is the main pathology. The cuticle was lost, cuticle has come back. So there are some videos which I am not going to show because there's a lack of, we can show this one. This is a very simple technique. So clean it, antiseptically prepare it, give a local anesthesia. This is the proximal digital block I am giving, 1 ml on both sides of the digit. Wait for 10 to 15 minutes till the effect of the anesthesia comes. And then you have to give a excanuate and give a tourniquet. So I have will give tourniquet after this. So I am using a surgical glove to use as a tourniquet. You can use other things also, like roller gauze. This tourniquet can also be used. So this is the way you put up a tourniquet. I know you have been explained very nicely in the workshops. So this is a tourniquet which has been placed, and then with the help of so maximum time tourniquet can be put is around 15 to 20 minutes. So with the help of a spatula, spatula or elevator, you can separate the nail plate from the nail fold as I am separating it. This is how it is being separated. So this is one of the main steps. Then you have to insert the spatula inside, and over that you excise the proximal nail fold, which I have explained in the photographs before. So this is now nicely separate, and you can see how much fibrous the nail folds are. So you just draw an imaginary line, maximum length could be 2 to 3 millimeters only. So full en bloc excision you have to do over this. So with the help of a surgical blade, you will do this. So I put the nail spatula inside the nail plate, the groove, and I am excising the proximal nail fold along with the lateral nail fold around 2 to 3 millimeters. Okay. The disadvantage of this technique is that the nail fold retraction is taking place and the nail plate becomes bigger by 2 to 3 millimeters. So these are the other videos. So post-operative care is non-adherent dressing. You give antibiotics of 5 to 7 days. And by 6 weeks, a good newly epithelialized proximal nail fold complete with a cuticle is regenerated. Then the second technique is Swiss roll technique. Generally, it is preferred for an acute peroneal surgeries. So you give a oblique incision at the junction of the proximal at the lateral nail folds. And this excision should be done till the mid-level of the proximal digital joints. So it is around 5 to 6 millimeter, and you reflect it like a fold. Both the sides you are given an incision. This nail fold is reflected like a flap, and with the help of a cotton gauze, you roll it and keep this open for 7 days in case of chronic paronychia and 2 to 3 days in case of acute paronychia, so that all the infection is exteriorized. But this technique is generally preferred for acute paronychia, runaround abscesses. Then third technique is square flap technique. Again, it's similar to the one like we do most of the nail surgery, like nail biopsy and all. You give oblique incision at the junction of the proximal and the lateral nail folds, and then you reflect the flap, and you have to just cut the fibrotic tissue like this. Not the nail fold, only the fibrotic tissue is cut. And then this gives a very good results, as you are just cutting the fibrotic tissue, so the nail fold is also not cut, as well as the nail plate length remains the same. So this is the technique I will demonstrate. You first antiseptically prepare the part, and after that you have to give a proximal digital block, 1 ml on both the sides. Again, wait for 5 to 10 minutes for the anesthesia effect to take up. Don't be in a hurry to perform the surgery after just giving the anesthesia. You have to wait for 10 minutes. Both you can take up plain lignocaine as well as lignocaine plus adrenaline. It is quite safe. Then you put up a tourniquet and exsanguination and tourniquet. So in this case, again, I have used a glove tourniquet. So you give a incision at the junction of the proximal and the lateral nail folds on both the sides, like I am giving this incision. And this incision is around 5 to 6 millimeter, roughly midway between the proximal interphalangeal joint. And then when this flap is formed, just evert this flap. So you have to extend the excision. This is the full total excision, and please make it only with the help of a nail spatula beneath the proximal nail fold, so that the matrix is not destroyed. And you evert this flap, and now you can, once we evert this flap, you can see such a fibrosis is there in case of this chronic paronychia, and you just cut through the fibrotic band, nothing else. Only the fibrotic band is taken out. So this has been cut. And you can see the fibrosis which is coming out. Now you place back the flap after cutting this fibrotic band and give sutures on both the sides. So this suture I am giving, just a simple skill suture, and which will be removed after 10 to 14 days. So this is the end result of the surgery, and after 4 months you see the nail fold is properly done and the cuticle has regenerated. Again, the major pain is one of the most important post-operative symptoms. You give NSAIDs, give antibiotics for 5 to 7 days, suture removal in 2 weeks, and complete healing happens in 2 weeks, and the cuticle is regenerated in 6 weeks. So, and the nail, if any nail dystrophy is there, it can be taken care in 6 months to 1 year. So the advantage of this technique is that virtually there is no proximal nail fold retraction and gives a better, superior outcome. So this is one of the articles I just came across recently. They have proposed for chronic paronychia, one of the treatment chemical sealing of proximal nail fold with cyanoacrylate glue, and done by Dr. Mukhtar and Dr. Sanjeev. So what they have done is they have inserted the cyanoacrylate glue in the groove of the chronic paronychia. As I told you, the cuticle is lost. So they say the results are quite good. I have bit apprehensions, Dr. Mukhtar may be here only, that basic pathology is the fibrosis which has taken place in the nail fold. So once you just seal that gap also, how it is going to treat chronic paronychia needs to be seen. So the most important points which I told before chronic, the management is the preventive measures. You have to avoid irritant contacts, avoid trimming of the cuticles, avoid finger sucking, use gloves, use a lot of moisturizer after hand washing, without which any surgical or medical procedure is a failure. So just a passing mention about acute paronychia. Dr. Rajneesh has already covered the surgical modalities. So this is chronic acute paronychia. You know it is caused by staphylococcal or streptococcus infections, sometimes pseudomonas infections also. So there could be of 3 types. One could be just abscess at the side of the nail, which is very easy to drain. Other could be runaround abscess, for which I told you the Swiss roll technique, both the sides. And third is when the pus tracks below the nail plate or it extends to the proximal around the joint also. So this could be a very dangerous one. So this is the end stage of chronic paronychias. So this is just the sides of the nail, lateral nail folds are involved. This is a runaround abscess, both the sides have been involved, and this, it is the pus has accumulated below subungually as well as that tract proximally also. So simple techniques of drainage are there. Suppose the pus is just around the proximal nail fold, you just need to put up the septal elevator, just lift up the lateral nail fold, the pus will track down. Or other technique is you can take a 11 number or 15 number blade, keep the sharp edge away from the nail and just elevate the nail fold. And third is the simple, with a simple needle you can, 21 or 23 gauge needle, just keep the bevel end up and just lift the nail fold, the pus will track down. Other could be what I told, the Swiss roll technique. If the pus has taken up in the pocket in the proximal side, so you have to just give incision, oblique incision. You should remember the nail unit incision line. Suppose the pus is on the lateral nail folds deep, you have to give a longitudinal incision. If it is on the proximal nail fold, it has to be radial excisions. So both the sides you just strike. If it is run around abscess, give incision on both the sides, just raise the flap and keep it open. For 2 to 3 days, the pus will exteriorize. In case of chronic paronychia, they had proposed for 7 days, but the point is that fibrosis has not been tackled for chronic paronychia. So Swiss roll technique is good for acute paronychias. So if you want to read more about surgeries and detailed about the nail disorders, you can go through the NSI official textbook of ONYCHOCON. And thank you so much.
Thank you, sir. Thank you for the wonderful slides and presentation. We mostly rely chemically to treat the cases, but something like surgical intervention could be of much help, sir. Thank you for enlightening us.
Thank you, sir.
Any questions from the audience? Thank you, sir.
In Swiss roll technique, after 7 days, you remove the sutures and the gauze you have put there, put back the flap back and just suture it. Okay, that just, it means exteriorizing the pus which has accumulated there. But that is a good technique for acute paronychia, runaround abscesses. But for chronic paronychia, the main pathology always remains the fibrotic nail folds. You have to remove the fibrosis, either with a square clamp technique or with complete excision of the proximal, this en bloc excisions. Okay.
Thank you, sir.
Thank you, sir.
Thank you so much, sir, for such a comprehensive and insightful session. I would request the speaker and chairpersons to kindly receive their memento. I would now request Dr. Shwatlina Pradhan ma'am and Dr. Sujala S. Aradhya ma'am to kindly come on the dais and chair the next session.
So this CB is very heavy to read out. So you just read and know who is Anupam Das. He doesn't need any recognition. I only recognize Anupam Das as my friend.
We call our next speaker, Dr. Anupam Das, to the dais to kindly deliver his lecture. And yes, as Dr. Shriparna said, such a heavy, Shriparna said, I'm sorry. So the first sentence that you can see, that's how I recognize him. He was a PG who had more than 200 publications by the time he completed his post-graduation. So yeah. Over to you, Doctor.
Thank you, Dr. Shwetlina and Dr. Sujala, for that sweet introduction. Now, this topic has been given to me by Dr. Shwetlina to speak on drug reaction and nail. Now, this is a very vast topic. I will try to cover the important aspects, the theoretical and the practical aspects within the next 10 to 15 minutes. I'll try to cover on the mechanism of how a drug can impact the nails, what is the mechanism, and what are the different things which can happen, starting from the nail matrix damage to nail bed damage to damage to the nail folds. Then of course there can be alterations in the nail blood flow, and of course pigmentation of nail, which is one of the most common side effects when it comes to drugs and nail. Of course, diagnosing a nail change because of drug is pretty difficult, because we need to rule out various other causes before we narrow down to a drug-induced nail change. Management, one of the most difficult things, and of course, preventive care is something which I'm trying to learn. So, this is one of the most common mechanisms when we think of drug reaction and nail, that is cytotoxicity to the nail matrix. This is probably because of direct accumulation of the drug into the nail matrix, especially your chemotherapeutic agents, especially the taxanes and antimetabolites. So what they do, like any other cell of the body, they target the rapidly dividing cells in the nail matrix and they disrupt the keratinization, as a result of which various changes can happen, commonest being the Bu's lines. Also there can be onycholysis, onychodystrophy, and onychoschizia. But Bu's lines are the commonest when it comes to this kind of mechanism. Apart from this, yes, this is another very common mechanism of drug-induced nail change, where there is a disruption of the nail bed leading to difficulty in the proper growth of the nail. And this is very commonly caused by the retinoid group of drugs, mostly your isotretinoin and acitretin. The nails can become very thin, they can become fragile, and there can be a reduction in the growth as well. This again, patients often present with digital ischemia, sometimes leading to Raynaud's-like symptoms. Most commonly, this is caused by the non-cardioselective beta blockers, and this is done by vasoconstriction and ischemia to the digits, which leads to ischemic changes. Again, this was there in the quiz also. Periangual inflammation and infection, this can again be one of the most common mechanisms of drug-induced nail damage. This can be caused by a wide number of drugs, starting from your indinavir and various other drugs. So retinoids, what they do is they disrupt the integrity of the nail fold, which predisposes the nail fold to become inflamed. So as a result of which there is inflammation, and inflammation can subsequently lead to paronychia and pyogenic granulomas as well. And yes, whenever we think of drug reactions and nail, melanogenesis interference is one of the most common mechanisms which leads to such changes. There can be pigmentation changes because of melanin deposition. There can be pigmentation changes because of direct accumulation of the matrix, direct accumulation of the drug product as well. And there can be pigmentation changes because of non-melanin pigments as well. Some of the common ones include your antimalarials and some chemotherapeutic agents. Now, this is the long list of drugs which can cause the nail matrix damage, starting from your chemotherapeutic agents, the taxanes, the anthracyclines. Then EGFR inhibitors are now one of the most commonly implicated agents because they are rampantly used by our oncology specialists. Apart from that, isotretinoin, that can lead to a number of changes. There can be indinavir, which can cause certain changes. Lithium, sirolimus, all of them can cause a lot of changes. Fluconazole, yes, it can also lead to some nail changes. So there you can see beautiful Bu's lines, where this patient was suffering from gastric cancer and he was put on docetaxel, cisplatin and 5-fluorouracil, and these kind of nail changes developed. Now the problem is it is very difficult to pinpoint as to which drug had caused this particular change. So I went through this report. I think in the report, the authors first attributed the change to all the 3 drugs. Later on, they replaced 5-fluorouracil with another molecule, and possibly the nail change is reversed. Now, whether the nail change is reversed because of a self-limiting nature or whether it was because of 5-fluorouracil, it is very difficult to establish. Again, this is another case of acute myeloid leukemia where daunorubicin and cytarabine was started on the patient, and these kind of nail changes developed. Now, very difficult to specify as to which drug might have caused such changes. Then there can be nail bed damage, commonest one being the onycholysis. There can be photoonycholysis, which is very common. Apart from that, there can be apparent leukonychia, which is not classical leukonychia. Apparently, the nail looks white, but it is not the typical case of leukonychia where we have 3 entities starting from your Muirke lines, half and half nails, and Terry's nails. Muirke lines, the typical change of apparent leukonychia because of leading to Muirke's lines, the most commonly implicated regimen is the CHOP regimen, which is used in various malignancies. And coming to drugs which can cause onycholysis and photoonycholysis, the list is huge, starting from tetracyclines to fluoroquinolones, of course sorolins, then you have NSAIDs, commonly thiazide diuretics, chloramphenicol, and various other drugs can also cause. So this is another case of photoonycholysis. You can see the patient, I think, was put on doxy. This again, you can see Muirke's lines, which was the patient was on doxorubicin, ifosfamide, and mesna irrigation. Now, what exactly had caused these changes, very difficult to specify, but I think we can narrow down to doxorubicin considering the probability of development of Muirke's lines following chemotherapeutic agents. Another case of half and half nails you can see where the patient was suffering from pre-B acute lymphoblastic leukemia. He was put on methotrexate and 6-mercaptopurine, and these were the nail changes which developed after, I think, 3rd cycle of chemotherapy. Coming to the commoner ones, that is the nail fold damage induced by drugs. The commonest ones which I have already discussed is your cancer therapies, the EGFR inhibitors. You have the pride complex where you have the paronychia, you have brittle hair, you have dryness of skin, you have regulatory abnormalities of the hair as well. That constitutes the pride complex, and it is mostly because of EGFR inhibitors. Most commonly geftinib, erlotinib, lapatinib, they very commonly cause such changes. Also, retinoids, indinavir specifically is notorious to cause pyogenic granuloma also. Sirolimus, everolimus, they also cause such changes. Again, this was a patient of colorectal cancer who was put on panitumumab, and you can see the changes of paronychia. You can see in the top second image, you can see development of pyogenic granuloma as well. Another case of pyogenic granuloma which is caused by geftinib, you can see. Coming to the nail blood flow alteration group, here the most notorious drugs are the non-cardioselective beta blockers, propranolol and metoprolol. They can cause ischemic changes, they can cause subungual hemorrhages as well. Another group of notorious drugs are your anticoagulants and antiplatelet agents. Also, it can be caused by certain anti-cancer drugs like your taxanes, bleomycin, VEGFR inhibitors, specifically your sunitinib and sorafenib. They can cause ischemic changes. Now, whenever we think of drug reaction and nail pigmentation is something which is one of the commonest things which we come across. Now, it can be because of a brownish, a blackish streak. It can be a yellow-brown streak. It can be a bluish-gray pigmentation. Very recently, very interesting, fluorescent pigmentation has been reported with molnupiravir. That is something very new. Blue-gray pigmentation that can be caused by, again, minocycline, amiodarone, which is very much there in the textbooks. Minocycline, that can cause a lot of other changes. Antimalarials can cause yellow-brown changes, penicillamine, hydroxyurea. Another interesting thing is, look, this pigmentation change may not be only longitudinal. There are reports of transverse melanonychia as well. We reported one case of imatinib-induced transverse melanonychia. Apart from that, topical application of drugs that can also lead to nail pigmentation, like your topical tar, topical miconazole, topical amorolfin, topical high-potency steroid, and of course intralesional bleomycin also. Now, this is a case of hydroxyurea-induced longitudinal melanonychia. The patient was put on this drug for essential thrombocythemia. This was our case which we reported. It was a case of imatinib-induced transverse melanonychia. The patient was suffering from CML, and this was the nail change. So coming to the diagnostic challenges, as I mentioned, it is very difficult to pinpoint whether the nail change is because of drug itself, and also since most of the patients are on polypharmacies, even if they are on chemotherapies, it's not a single agent chemotherapy, it's always combination of drugs. It is again very difficult to pinpoint as to which drug has caused this particular change. Also, there are non-specific symptoms which can mimic other nail diseases also. Apart from that, the main problem is the onset is very delayed. Because of the slow nail growth, both toenails and fingernails, the nail changes, the nail pigmentation or any other change that can appear weeks or months after starting the drug. So the temporal association may not hold true in drug-induced nail changes. Apart from that, under-reporting, again, this is often overlooked in clinical trials and often under-reported by patients. So we need to be very, very meticulous in history taking whenever we are coming across whenever we are suspecting any drug-induced nail change. Management challenges, again, as I have mentioned, the same thing since it's a polypharmacy and so far as chemotherapeutics is concerned, multiple drugs are started all together in a single patient, so it is very difficult to identify as to which drug had caused this particular change. Preventive care, I think this should be the most important strategy whenever we are starting any chemotherapeutic drug. We need to protect the nails from trauma. That is probably the most important thing. Gloves should be worn for household works, tight-fitting shoes, high heels, those may be avoided. Patients must protect their hands while doing their hobbies. Patients must protect their hands while doing any household cleaning work. The nails must be always kept short, straight, and the edges must be filed so that scratching, catching, and breakage and all those things that can be reduced. One of the most important strategies when it comes to prevention is applying a lot of emollients to cuticles and nail beds on a daily basis so that dryness and xerosis do not contribute to all those nail changes. Very importantly, breathable socks, they often help in absorbing the moisture. Avoidance of harsh products is also helpful. Now, a few interesting things I picked up from that textbook of oncology, like oral biotin 2.5 milligram per day. This often helps in as a preventive care. So whenever maybe we are starting chemotherapy or any such drugs, and oral biotin, that may be helpful in delaying the development of nail changes or maybe total prevention also. Antiseptic soaks, specifically diluted vinegar or chlorhexidine solutions, they also have good results. There are certain hydrating lacquers which specifically contain your hydroxypropyl chitosan. Now that is something which keep the nail very much hydrated and chances of dryness-induced, xerosis-induced damage is less. Cryotherapy, this is something works well like using frozen gloves or socks, especially when we are planning chemotherapy infusions with the taxane group, docetaxel and paclitaxel. What they do is they reduce the risk of onycholysis. They also reduce the chances of development of subungual hematomas. Also, whenever we are starting, say, whenever we are starting drugs which can cause photoonycholysis, which have a propensity to cause photoonycholysis, photoprotection may be advised, and opaque or a colored nail polish may be given so that direct sunlight exposure may be avoided so that the ultraviolet light induced nail damage can be prevented. So just to summarize, drug reaction and nail, we have to have a very high index of suspicion whenever patients do come to us. And if that particular differential diagnosis comes to our mind that particular nail change could be because of drugs, we need to take very important history, not a history of last 4 weeks or 6 weeks drug intake may be helpful. We need to go back to maybe 3 months, 4 months, what all new drugs the patient has been started on. Apart from chemotherapeutic agents, there can be very simple drugs like your fluconazole, terbinafine, griseofulvin, fluoroquinolones. They can also cause a lot of nail changes, and in order to avoid multiple doctor visits and unnecessary investigations and treatment, if a proper drug cause is identified, we can always help our patients. Thank you, organizing and scientific team, for having me here. Thank you, everyone.
Do we have any questions from the audience? Thank you, Dr. Anupam.
Thank you.
Thank you, sir, for such a comprehensive session. I would request the speakers and chairpersons to kindly receive their memento. Now for the next session, I would like to request Dr. Govind Kumar sir and Dr. M. Mukhtar sir to kindly join us on the dais to chair the next session.
So for next session, I will call Dr. Shivani.
Good morning, everyone. My topic is clinical approach to nail psoriasis. As we all know, nail psoriasis is a major clinical manifestation prevalent in majority of psoriasis patients. Nail involvement is seen in 10 to 78% of psoriasis patients. Isolated nail psoriasis is found in 5 to 10% of cases. Nail psoriasis is associated with significant pain and physical impairment and difficulty in manual dexterity. Psoriasis patients with nail involvement have high risk of developing psoriatic arthritis. Now coming to brief pathogenesis, there is immune-mediated keratinocyte proliferation and inflammation directed to nail matrix and bed. Mainly it is T-cell mediated inflammation. Now I will come to clinical evaluation. In clinical evaluation, first of all, we take history, then we do nail examination of all 20 nails, skin and scalp examination, and joint evaluation. Now coming to clinical features of nail psoriasis, it is broadly categorized into nail matrix psoriasis and nail bed psoriasis. Nail matrix psoriasis features include pitting, nail plate thickening and crumbling, leukonychia, transverse grooves, trachonychia, and red spots in lunula. And nail bed psoriasis features includes oil spots or salmon patches, distal onycholysis, subungual hyperkeratosis, and splinter hemorrhages. This is the clinical photograph. Now I will individually deal with features of nail matrix psoriasis. First one is pitting. Pitting is the commonest manifestation of nail psoriasis. It is punctate surface depressions on the nail plate. Psoriatic inflammation in proximal nail matrix produces loose parakeratotic cells in the surface portion of the nail plate. As the plate grows out, these cells are exposed to environment and shed, resulting in the pits. Typical psoriatic pits are irregular, large, and coarse. More than 20 pits is suggestive of nail psoriasis. Now coming to Bu's lines. Bu's lines are serial transverse grooves across the nail plate. It is caused by temporary interruption of matrix proliferation. It indicates episodic disease activity. Now coming to leukonychia. It presents at white spots on the nail plate. It occurs due to inflammation of mid or distal matrix, causing accumulation of trapped parakeratotic cells within the nail plate. It moves distally with nail growth. Now coming to nail plate crumbling, it presents as fragile dystrophic nail plate with fragmentation. It is caused by severe chronic matrix inflammation. It is a marker of severe nail psoriasis. Now, nail plate thickening and discoloration. Hyperproliferation of nail matrix causes thickened nail plate, which plays a major role in yellowish discoloration of nail plate. Red spots in lunula. It presents as erythematous discoloration in lunula. It occurs due to dilated capillaries and inflammation in distal matrix. Now, coming to features of nail bed psoriasis. The first feature is oil drop sign or salmon patch. Focal nail bed parakeratosis produces oil spot or salmon patch. Extension of oil patch to free edge resulting in onycholysis, which has reddish brown proximal margin. It is the most specific sign of nail psoriasis. Now, next one is onycholysis. It is the distal separation of nail plate from nail bed. It occurs due to parakeratosis and inflammatory exudate lifting the nail plate. Well-demarcated margin of onycholysis with erythematous border is suggestive of nail psoriasis. Subungual hyperkeratosis is the accumulation of keratinous debris beneath the nail plate. It occurs due to hyperkeratosis of nail bed. It is most marked distally and extends proximally. Now, splinter hemorrhage, it presents as thin longitudinal reddish brown streaks on the nail plate. It occurs due to capillary bleeding underneath the thin suprapapillary plate of psoriatic nail bed. It occurs in distal third of the nail plate. One more feature of nail psoriasis is nail fold psoriasis. It is like other lesions of psoriasis elsewhere on the body. As typical psoriasis plaques with signs of chronic paronychia, and there is also loss of cuticle. It is found in patients with psoriatic arthritis with nail involvement. Now coming to pustular variant of nose psoriasis, it is found in acute generalized pustular psoriasis and palmoplaster pustulosis, and also occurs in acrodermatitis continua of Halipeu. Now coming to severity index of nail psoriasis, that is nail psoriasis severity index. It is an objective method to measure the severity of nail psoriasis. Nail is divided into 4 quadrants, and presence of any manifestation in nail matrix and nail bed is taken into account. Each nail has matrix score of 0 to 4 and bed score of 0 to 4. Maximum score for each nail is 8. To increase the sensitivity of NAPSI, modified NAPSI was proposed. It does not divide nail into quadrants. It assesses the severity of individual nail features, matrix features, as well as nail bed features. Now, coming to the differential diagnosis of nail psoriasis. First one is onychomycosis. Onychomycosis more commonly affects the toenails, but nail psoriasis affects fingernails. Pits is a common finding in nail psoriasis, and pits are rarely seen in onychomycosis. And the matters brownish halo at the proximal edge of psoriatic onycholysis is characteristic in nail psoriasis, and no such halo is seen in onychomycosis. Nail plate on histopathology shows no fungal hyphae or spores. It shows nail bed hyperplasia and hypergranulosis. No hypergranulosis is seen in histopathology of onychomycosis. This onychomycosis, KOH mount is positive, but nail psoriasis, in nail psoriasis, KOH mount is negative. Now, the second differential diagnosis is lichen planus of nail. Longitudinal ridging and teresium formation is in favor of lichen planus of nail. In nail psoriasis, there will be features of pitting onycholysis. Now, trachonichia is the third differential diagnosis. In idiopathic trachonichia, there is sandpaper-like rough nails appearance. There is uniform involvement of all nails. In psoriatic trachonichia, there is associated skin lesions. It coexists with classic psoriatic signs. Now, the next differential diagnosis is pitting in alopecia areata. Pitting of alopecia areata is seen as shallow, regular, and uniform. But in nail psoriasis, the pits are large, coarse, and irregular. Now, coming to investigations, KOH mount and fungal culture is mandatory, as onychomycosis sometimes coexists with nail psoriasis. And there is another non-invasive technique of diagnosis, that is dermoscopy. And nail biopsy is indicated in difficult cases. These are the dermoscopic findings of nail psoriasis. Dilated tortuous capillaries in the nail bed, coarse pits, nail plate thickening, and trachonichia, transverse groups. These are the dermoscopic features. Now, coming to nail unit biopsy. Unit biopsy, nail bed and nail matrix histopathology shows varying degree of uniform hyperplasia, spongiosis, hypergranulosis, spongiform pustules, parakeratosis with neutrophils. These are the various sites of nail biopsy. Now coming to newer techniques, in nail psoriasis, like ultrasound. Nail psoriasis, nail plates shows hyperechoic parts or loss of definition, which can involve only the ventral plate or both plates. Another newer one is optical coherence tomography. Now coming to the prognostic indicators of nail psoriasis. Nail disease severity correlates with arthritis risk. Matrix disease is slow response to treatment. Nail psoriasis is a diagnostic art. We should always exclude a fungal infection. A nail disease may predict systemic involvement. Thank you.
Very nice presentation. So any questions? Thank you, Dr. Shivani.
Thank you, everyone.
Thank you so much, ma'am, for such a wonderful session. I would request the speaker and chairpersons to kindly receive their memento. I request Shivani ma'am to kindly receive her memento. Now for the next session, I would request Dr. Pallavi Kashyap ma'am and Dr. Shri Parna Dev ma'am to kindly come on the dais and chair the session.
I would like to invite on stage Dr. Shivani Shekhar to kindly present her awesome presentation as usual on genodermatosis nail changes. Dr. Shivani, over to you.
Good afternoon, everybody. Thank you, ma'am, for such kind words. Since we are running late, I will be short and quick. We are going to discuss nail changes in genodermatosis. Now, as I remember myself as a PG student, as well as now, nail is a difficult topic and genodermatosis is yet another difficult and boring topic. So I would like to keep this session very clinical and very crisp. So let's start. So first let's discuss why we are discussing this, why we are bothering about nail when we are talking about genodermatosis. So as we all know, genodermatosis translates to inherited genetic disorders, skin disorders, and it is an admixture of cutaneous and systemic findings. So since they are rarely encountered in clinical practice, cutaneous clues are very much necessary for us as a dermatologist to think that there is something lying beneath the external changes in skin. So since nail develops from same embryonic tissue as skin and mucosa, so they mirror these changes too. So since we are dermatologists, since we are the first doctors who such people come to, so we should know what are these changes so that we can think about that there is something lying underneath. So there are three types of disorders, genodermatosis. Some are with characteristic nail changes. That means once you spot these changes in your clinic in your practice or in your indoor, you will think that yes, this may be the diagnosis, and you think of other changes on the skin. So such disorders, let's discuss one by one. So if this type of nail presents to you, this is thick yellowish brown colored nail which may present at birth or develop during neonatal period. There is dystrophy of all the 20 nails, and this feature is common in all the variants of this disease. There is a specific change which is quite characteristic of this disorder, that there is upward angulation of the distal free edge of the thickened nail plate, which is due to progressive distal thickening, and this is a distinct feature which differentiates this disorder from other disorders with hyperkeratosis, and there may be recurrent painful paronychia due to these changes in the nail. Yes, again then we will search for, there will be painful focal palmoplantar keratoderma, there can be foamy white mucosal plaques which is leukokeratosis of oral mucosa, and there will be generalized cysts and steatocystoma all over the body. Natal teeth may be present, hoarseness of voice and laryngeal stridor may be present in children, and pili torting may be present. So there are nail changes, there are hair changes, there are mucosal changes, palms and soles are involved. So this disorder is pachyonychia congenita. I would not go in details of the genetic changes, but yes, these are the features which when comes to you, when you see such nails with 20 nail dystrophy, thickened nails, yellow nails right from the childhood, with these changes in palm, soles and mouth, then you will think of something which is pachyonychia congenita. Next disorder. When you have someone who presents to you with anonychia or non-progressive micronychia which is present since birth. Now in this disorder, nail is either small or it is absent. Radial side of hands, that is thumb and index finger, is most commonly involved. Nail hypoplasia in a certain finger. In one finger, if you will see the changes, it is more on the medial side, but all over as in the hand, the changes are more on the radial side of the hand. And there is triangular lunula, which is highly predictive of this disorder with apex in midline. Then there will be what clinically patient will present with. If a child is presenting to you with early onset knee joint osteoarthritis, which is very, very rare, there can be webbing of digits. The absence of skin crease on dorsal speck of distal interphalangeal joint is more specific than the nail changes for this disorder. Proteinuria can be present in nephrotic range. Patient may present to you with generalized anasarca that is seen in nephrotic syndrome. And if you will go for X-ray, you will find posterior iliac horns, hypoplastic patella and hypoplasia of proximal radius and ulna. So that patient may clinically present to you with difficulty in the movement at the elbow joint. So what is this disorder? This is nail patella syndrome. Next disorder that we will be discussing is, again you are getting thickened yellow nails in which all 20 nails are involved. Color in this disorder may vary from yellow to orange. If there is Pseudomonas superinfection in such nails, there may be greenish discoloration. Specific nail findings in this disorder are longitudinal overcurvature of nail, lunula is obscured, there is absence of cuticles, and there is history of very slow nail growth. Okay, so there is change in curvature, the lunula is absent, there is cuticle is absent, and there is very slow nail growth. And also if you go for systemic findings, so patient will complain of that there is respiratory tract illness. That is, they will complain of sinusitis, bronchitis, recurrent bilateral pleural effusions or bronchiectasis, and there may be primary lymphedema. So these disorders, when you see such changes in nail and there are these systemic findings, the diagnosis is yellow nail syndrome. And in 30% of cases, only lymphedema is the presenting feature, and in other 30% of the cases, only nail changes can be present. So in all the genodermatosis, all the findings may not be present. This must be kept in mind. Next, now this picture is quite diagnostic of its own. A person is shown, there is some blistering all over the face, the photo-exposed areas on hands, on face. So photoonycholysis is present, and there is marked koilonychia in nail. Along with photosensitivity, skin fragility and blistering, pigmentary changes such as hypo or hyperpigmentation, hypertrichosis, milia formation, and pseudosclerodermatous changes. So these are characteristic of porphyria. If such patient is presenting to you, the skin is only telling the tale of the patient. They will be complaining to you with recurrent blistering, and then there are milia formation and pigmentary changes. Then you will think of, yes, this is porphyria. Now there are some specific porphyrias. There are n number of porphyrias, as you may all remember from your biochemistry classes. So what porphyrias are involving the skin and nails? So if there is there are hepatic involvement along with these changes in skin and nail, then that is porphyria cutanea tarda. If their patient is presenting to you with acute abdominal pain and neurological symptoms if present, you will think of variegate porphyria. If there is red urine and erythrodontia, then it is congenital erythropoietic porphyria. And if there is skin pain on sun exposure is a very characteristic finding. Elliptical scars and bulla on photo-exposed area, then it is erythropoietic protoporphyria. So as dermatologists, we need to know these 4 types of porphyrias because there is skin involvement characteristically present in these cases, and there are specific systemic involvement as well. So these pointers will help you in your clinical diagnosis. Next case. Now this I think every one of you must be knowing. V-shaped notch is present on the free edge of nail plate. There is alternate red and white longitudinal bands on nails, which is also known as candy cane nails. Ridging, fragility and brittleness is present, and splinter hemorrhage may be present or absent. Another findings, this is very characteristic face, red and brown hyperkeratotic papules, which we think as dirty, warty papules and plaques, which we characteristically say in every, we are seeing it in every textbook, our teachers are telling it to us, and along with, which is very much prone to secondary infections, and sun exposure, friction, heat and sun. These 4 factors exacerbates this condition. There is distinct white and hard papules on hard palate, which is famously known as cobblestoning. So I think the diagnosis is very clear. This is Darier's disease. So moving to the next slide, periangular fibromas, again very characteristic, also known as Cohen's tumor. Red comets. Now this is a very specific thing which I found not commonly found in the textbooks. Red comets are partially blanchable erythematous streaks with distal bulging on nail plate, which spares the free margin of the nail. It is due to subungual fibroma. So red comets are due to subungual fibroma. Other non-specific changes are nail dystrophy, onychogryphosis and splinter hemorrhages. Now, if you go to the examining the skin, there are ash leaf macules, adenoma sebaceum right from the childhood, again is very characteristic, and shagreen patches mostly present on the lower back. So this is tuberous sclerosis complex. So now when patient comes to you with tuberous sclerosis complex, don't stop there. What you need to know that other systems may also be involved, and that is very important. Your role as a dermatologist do not end when you diagnose tuberous sclerosis. You must know which physician, which doctor to refer to the patient so that underlying things can be diagnosed. So brain can be involved, there can be subependymal tumor. Eye can be involved, there can be retinal hematoma. Lungs, there will be lymphangioliomyomatosis, which is commonly known as LAM. Cardiac examination is necessary for diagnosis of rhabdomyoma, and renal evaluation for angiomyolipoma. So there are many systemic involvement in tuberous sclerosis. Once you diagnose a patient with TSC, don't stop there, refer them to the correct physicians. Next case. Now this you can see there is some hemorrhages on the nail, and there is hemorrhages on the mucosa and on the skin as well. So this you can see that very characteristic, nail, skin, mucosa, everything is involved. There is hemorrhages, punctate hemorrhages. So punctate red dots, which are blanchable red dots on nails, which give rise, which may lead to splinter hemorrhages on rupturing, along with history of recurrent epistaxis starting early from the infancy, and there is a familial history of multiple mucocutaneous and internal hemorrhages. The diagnosis is Osler-Weber-Rendu syndrome. So these are some of the clinical diagnoses in which when you see the nail, you think of this diagnosis. So these are genodermatosis with specific nail changes. Now we will discuss with significant nail changes. When patient comes to you, the nail changes are significant enough to attract attention, but not characteristic to clinch the diagnosis. So let's discuss. Now you can see the nail is brittle nail. That is, there is onychorexis, there is brittle nails. The texture is abnormal. And what you see in the other slide, there is some, the hair is sparse. The patient is having sparse hair. And there is some ichthyotic changes on the skin. And if you will go for double polarized dermatoscopy or electron microscopy, you will see this change in hair, which is very characteristic, which is known as tiger tail appearance. So yes, again, as I have already told, hair finding is quite characteristic for this diagnosis, not nail finding. There is scalp hair, eyebrows and eyelashes are short, thin, brittle and dry. And again, as I've already told, tiger tail appearance in double polarizing dermatoscopy and electron microscopy. Also in dermoscopy, if you will do, you will find trichorexis nodosa and trichoschisis, which is very characteristic. Skin is ichthyotic, and patient is having short stature and a characteristic facies, which is known as doll-like or aged appearance, as you can see in the picture. If you will take the history of the mother of the patient, she may tell that she was having some pregnancy-related complication, most commonly that is elevated hypertensive changes in the pregnancy. So this is trichothiodystrophy. Next case. we can see there is psoriaciform nail changes, thickening and discoloration of nail plate along with subungual hyperkeratosis and splinter hemorrhages, which are seen in all type of palmoplantar keratoderma. You must all be seeing. But if it is along with scleroatrophy of the hands, diffuse palmoplantar keratoderma and hypoplastic nail, which is the triad here, and there is prominent lunula, elongated cuticles, and V-shaped notch are special features of this disorder, and there are increased chances of squamous cell carcinoma. So if patient is presenting to you with scleroatrophy, means parchment paper like hands, palmoplantar keratoderma and hypoplastic nails, and there are increased chances of SCC, this is Hurier's syndrome. This is a specific type of keratoderma. You must be thinking about this when this triad is present. Hypoplastic nails, scleroatrophy of the hands, and diffuse palmoplantar keratoderma. Next slide, if patient is coming to you and showing you their fingers, they are telling there is periungual, you are seeing periungual hemorrhagic bulla, dried up bullas, and discoloration and severe dystrophy and onychogryphosis along with anonychia. This is just EBS, EBD and EBJ. You will think of epidermolysis bullosa complex. Now in simplex, the nail changes are minor. In junctional and dystrophica, the nail changes are major. There may be anonychia, there may be dystrophy. So these findings along with skin findings will point towards mechanobullous disorders. Now again, if you are getting a patient with long and thick cuticles and several fingernails with parchment-like skin, again parchment-like skin, gross nail dystrophy with pseudosyndactyly, palmar fissures are absent, history of acral bulla in infancy progressing to poikiloderma with age along with photosensitivity, and if there may be gum problems present. So this all points towards the diagnosis of Kindler syndrome, poikilodermatous disorders, Kindler syndrome. Okay. Now again, if you are getting poikilodermatous disorder, racy reticular pigmentation, that is poikiloderma, along with abnormal finger and toenails with ridging, flaking or poor growth, early gray hair, hyperhidrosis and short stature. Now this is a triad. You can see dystrophic nail, poikiloderma, and like mucosal lacy hypopigmentation. This is dyskeratosis congenita. If patient is presenting to you with this, there is extensive systemic examination is required. Almost every system can be involved, so you must refer these type of patients. This triad you must remember: dystrophic nail, poikiloderma, along with some leukokeratosis of the oral mucosa. This is triad of dyskeratosis congenita. Now with non-specific nail changes. Now these nail changes are non-specific, very commonly seen in acquired nail disorders as well. So these are non-specific nail changes. You cannot point towards diagnosis when you see these cases. So in various ectodermal dysplasia, I am not going in detail, but this is a chart. If PGs want to take a picture, they may. This various ectodermal dysplasias may present with onychodysplasia, nail dystrophy, anonychia, brittle nails. So these all we have discussed a number of times. But in specific disorders, these are the changes which are quite commonly seen in other acquired nail disorders, such as LP and psoriasis as well. Now another syndrome which we can talk about, in which nail dystrophy is seen. Small and dystrophic nails are present, photosensitivity and blistering is present. Poikiloderma is again present with parchment-like atrophic changes. Whenever there is parchment-like atrophic changes, you must think of photosensitivity and blistering, because if early age photosensitivity and blistering is present, in late changes you will see this parchment-like changes on the hands. Sparse hair, eyebrow and eyelashes again is present. There is early cataracts in the present. If a child is presenting to you with cataract, nail changes, skin changes, and there is high risk of developing osteosarcoma, this case is Rothman-Thompson syndrome. Okay? So if there is a patient with dystrophic nails, photosensitivity, parchment-like changes, early cataract is quite specific, you must think of Rothman-Thompson syndrome. Now these are some of my last slide. Nail contour changes. What are the nail contour changes which can be seen in some genodermatosis? Slender and longer nails, these are seen in Marfan syndrome. Marfan syndrome, there is obviously the patient itself says that he or she is having Marfan syndrome. Very long patient, very long limbs, very slender fingers and very long nails. So this is Marfan syndrome. Again, if patient is presenting to you with koilonychia, tracheonychia and angiokeratoma, underlying angiokeratoma, which causes this type of changes, which is known as turtle back nail. So this is seen in storage disorders, Fabry disease and fucosidosis. So this type of changes, turtle back nail, this is seen in Fabry disease and fucosidosis. Again, we will be discussing some nail color changes. This type of pigmentation, one we saw in Osler-Weber-Rendu syndrome, but there was inherited mucocutaneous hemorrhages. But this is quite not red, this is black. Actually what you can see, this is brown to black. And this type of changes is also seen in the mucosa with some melanonychia as well. And if you will go in deep, you will come to know that patient is having some polyposis as well. So I think all will be guessing this is Peutz-Jeghers syndrome. Similarly, if patient is presenting to you with like this type of double melanonychia along with this type of pigmentation in gums, then this is Lausier-Hunziker syndrome. And if patient is presenting to you with this, like this type of changes, brownish discoloration of nail, this is ochronosis. So with this, I would like to end my session. This is my references. Thank you all for being such patient listeners. Thank you.
It was a great, elaborate presentation, Dr. Shivani. Thank you. Any questions from the audience? Thank you so much.
Thank you so much, ma'am, for such an informative session. I would request the speaker and chairpersons to kindly receive their memento. I would like to request respected Dr. Ranjit Kumar sir and Dr. Aditi Snehal ma'am to kindly come on the dais and chair the next session.
So, as ma'am is already here, so inviting Dr. Pallavi Kashyap ma'am to give the presentation.
Thank you so much. A very good afternoon to everyone, and special good afternoon to my respected chairperson. So today's presentation is Dermatologist's Guide to Safe Nail Aesthetics and Risk Benefits Quotient. The dual role of nail aesthetics is cosmetic while enhancing the appearance and personal grooming. Therapeutic is basically the camouflaging dystrophy caused by psoriasis, lichen planus, brittle nails, while the medical treatment is still taking its effect. The clinical goal is basically achieving the aesthetic satisfaction without compromising the physiological integrity of the nail unit. Hence, balancing the cosmetic outcomes with the risk-benefit quotient becomes very important. So what is the concept between risk factor quotient? It is a structure score to quantify patient's procedure risk before nail aesthetics, which includes nail fragility, skin sensitivity or allergy history, frequency of nail exposure, then immune and systemic conditions, professional training, and the technique level of the aesthetician. Then the risk factor quotient scoring system, there's no standard scoring system, but one of the proposed scoring systems says that you can score each factor from 0 to 3. And what are the factors which you can score are nail fragility, skin allergic sensitivity, exposure frequency, immune and systemic illness, nail technician skill levels, and the categories are divided as low risk from 0 to 5, moderate, 6 to 10, and high risk is more than 11. So the risk-benefit quotient, what benefits are actually from the aesthetics? It improves the quality, patient's quality of life, and again, the protection of damaged nail plates from further environmental trauma. Then what are the risks basically? The mechanical overbuffing leading to traumatic onycholysis, chemical contact dermatitis and brittle nail syndrome from the solvents, and again, biological, which is increased susceptibility to fungal, which is onychomycosis or bacterial infections. So what are the volatile organic compounds profile? So depending upon nail polish, gel manicures, acrylic adhesives, and nail paint removers, the common volatile organic compounds are basically ethyl acetate, isopropyl alcohol, methyl ethyl ketones, then butyl acetates, ethyl toluene, and hydrocarbons like isoparaffins are present in some removers as well. So the major aesthetic complication is allergic contact dermatitis, primarily caused by the methyl acrylates like HEMA, and then diphenyl phosphine oxides with photoinitiators, then cyanoacrylate in adhesives, and formaldehyde in the hardeners, and can cause pulpitis as well, which can lead to permanent nail loss also. The UV radiation from the UV radiation from the nail lamps can penetrate into the skin, leading to aging, DNA damage, which can further be linked to carcinoma. Cellular damage, UV lamps can cause cell death or even mutations of the human skin cells. Now, again, the cumulative effect can lead to squamous cell carcinomas and squamous cell carcinoma in situ, that is Pavan's disease. Then the trimethyl benzol diphenyl phosphine oxide toxicity, which are basically the photoinitiators and are used to harden the nail post UV exposure, can lead to periungual dermatitis, higher risk of allergic hand dermatitis, and nail fold inflammation as well. Again, the infection vectors, the contaminated tools or the water baths can lead to paronychia, pseudomonas screen nail syndromes, or periungual warts, even onychomycosis. Then major aesthetic complication, again, the mechanical and chemical damage can lead to disruption of nail plate, cuticle trauma, onycholysis, subungual hematomal breach. Then acetones used in the removers can lead to dry, brittle, and lusterless nails. Overbuffing can thin the nail plate, leading to splitting and weakness. Then which people are under the high-risk scenarios? People who are diabetic, immunocompromised patient, even the nail technicians with chronic dermatitis, prolonged acrylic and gel wear nails, people, and then again trauma sports who are climbers and runners. So what are the technician hazards? The nail technician can face health hazards from long-term exposure to the volatile organic compounds, and these risks can lead to both acute and chronic health issues. The factors contributing to these are overexposure, use of unsuitable personal protective equipments, again minimal health and safety training. Then what a dermatologist's recommended safe standards are: 5 free movement, that is advising patients to choose nail polishes which are free from formaldehyde, toluene, dibutyl pathate, then again camphor and formaldehyde resin. Cuticle preservation is very important because it is a seal between the nail and the skin. And gentle grooming, nails should be cut straight, filing in one direction only. Then solvent management, using non-acetone removers where possible and limiting acetone soak-off times for the gels. Then what are the protective protocols for gel manicures? UVA shielding, that is applying broad spectrum sunscreen. Then wearing protective gloves, choosing LED lamps, not the UV radiation, limiting the frequency, getting gel manicures lesser frequently. Then hydration, urea-based and lactic acid creams can be used. And nail holidays, that is mandatory 1-week break after every 3 weeks to allow for the nail rehydration. There are certain reforms also attempted by the brands. They are reformulating to reduce the volatile organic compounds and replace them with safer alternatives. Then again, safety consideration are being taken. Well-ventilated workplaces to minimize the inhalation exposure. Personal protective equipment recommendations include good ventilation, masks and respirators when appropriate, eye protection during application, and again, reading the safety data sheets is very important. What are the Salor safety checklist? Sterilization is very important. Ensure that the process is medical grade autoclaved. Then again, pedicure hygiene. The whirlpool foot baths should be avoided. And then pipeless line basin should be used. Then of course, verifying the credibility of your technician is equally important. Hence, I conclude that nail aesthetics are essential component of modern dermatological care, but patient education becomes mandatory on chemical literacy and protective grooming. Specifically reduces the incidence of chronic nail unit disorders. Thank you. So a healthy nail is the foundation of a beautiful nail.
So, ma'am, would like to ask most viral question. Anyone going for marriage in 1 to 2 week or 1 month, they come to us and they say, like, should we go for the nail treatments? So what should be done? What should we counsel them to do and what not to do?
Actually, as I said, we should ask them that what is the frequency of their using nail paints and how often are they using?
For marriage purpose only. Like before going to marriage, they usually do the nail art and...
if their nails condition is okay, you can permit them because you can't upset the bride, right?
And the precautions, where to get it and what not to do.
Certainly, they have to go to a nice professional, and then safety measures, they should actually prevent the cuticle. That is very much important.
Yes, the cuticle damage is very common. The most common, after they come with the nail thing, the cuticle damage is there.
Certainly.
And peri-angul area also is very much damaged.
Yes.
So, what treatments you give for the nail damage after that happens?
That depends what kind of damage has been happened. So perfectly hydration should be there. If any fungal infection is there, then certainly antifungals should be given. If paronychia has happened by chance, then the therapy has to be given.
Most common is paronychia.
Yes, yes.
Thank you, ma'am.
Thank
Very
you.
nice session.
Thank you.
Anyone
Thank you, everyone.
would like to ask anything? Any audience member? Thank you, ma'am.
Thank you.
Thank you so much, ma'am, for such an amazing session. I would request the speaker and chairpersons to kindly receive their memento. For the next session, I would request Dr. Anil Kumar Soni, sir, and Dr. Ranjit Kumar, sir, to kindly join the dais and chair the session.
I like to invite Dr. Madhu Singh to come here and present her topic on brittle nail causes to cure.
Good afternoon, everyone. I'm here to have a quick session on brittle nail from cause to cure. Brittle nail or nail fragility affects 20% of the population, especially in the women less over the 50 years of age. It mostly affects the fingernail as compared to the toenail, clinically characterized by split, flake, crumble, soft and loose elasticity over the time. Before moving ahead, we will understand the origin of the nail plate. It is derived from the proximal nail plate. It is a fully keratinized structure having 25 layers with a thickness of 0.5 to 1 mm. As we previously mentioned, it is derived from the proximal nail matrix. 1/3 is derived from the distal nail matrix and the nail bed. Nail plate is mainly dependent on the two factors, vascularity and inflammation. If any of both of them is hampered, this will lead to the alteration in the nail plate. Causes of the brittle nails are factors that alters the nail plate production and the factors that damage the nail plate. Due to any of the reason, if proximal matrix got damaged, we have a thinning of the entire nail plate. But if distal matrix got affected, we have a damage of free edge of the nail plate. Here are the few causes of the brittle nails. In this, firstly, we have idiopathic, which is one of the most common cause of the brittle nail. Second one is physiological factor. In this, female gender and the old age. Third one, dermatological condition, in which we have eczema, lichen planus, psoriasis and alopecia areata. In systemic disease, we have iron deficiency anemia, hypothyroidism, hyperthyroidism, diabetes mellitus, peripheral vascular disease. In nutritional deficiency, we have iron, biotin, vitamin A, B, C, D, H, that is biotin, zinc and selenium deficiency. Systemic infections like leprosy, HIV, AIDS and syphilis, all these will cause to the brittle nail formation. In genodermatosis, we have Darius disease, Haley disease, and trichothiodystrophy. And last, we have trauma. All these factors will lead to the formation of the brittle nail. Clinically, we are going to deal this in three aspects. First one is onychorexis, frequently seen among the women of middle age. It is mostly due to endogenous factor, characterized by longitudinal splitting and the shallow parallel furrows running over the superficial layers of the nail, also known as embankment of the cashel. Both the picture represent the findings below. It ranges from the few superficial splits to the multiple deep fissure. Next is lamellar onychocesia. Basically, it caused due to defective intercellular adhesion, which causes the horizontal lamellar splitting of the nail plate, depicted in the left side photo. And due to the loss of sulfur-rich amino acid cysteine and the disruption of the lipid, that is ceramide, due to disruption of the bonding, we have this lamellar onychocesia. We encountered this case mostly in case of repetitive wet works and the frequent hand washing patients. Superficial granulation of keratin. Brittleness is mostly confined over to the dorsal nail plate, but we shouldn't confuse this condition with the superficial white nail onychomycosis. Moving ahead, we are going to discuss idiopathic nail brittleness, that is brittle nail syndrome. It is the most common cause of nail brittleness, exclusively found in the fingernails. It is most commonly encountered in the female. Normally we have 5% of the lipid, but over the age, as menopause achieves, there is a decrease in cholesterol, leading to the alteration of the nail plate and the formation of the brittle nail. It is also seen due to reduced water content of the nail plate, that is less than 16%. Here are the few of causes of secondary nail brittleness. In this, firstly, we are going to discuss inflammatory nail disorder. First one, psoriasis. 50% of the patients suffering from psoriasis are associated with nail brittleness. When the proximal nail involved, nail plate present with irregular and the deep pits. But in severe case, we are going to have a friable and the brittle nail, both picture depicting the same condition. Moving ahead, lichen planus. In this, 10% of the patients are affected. Depending on the degree of inflammation and the nail changes, thinning, longitudinal leading and splitting of the nail plate seen. In alopecia areata, 2/3 of the patient is affected. Pits, onychorexis, thinning and trachonicia is seen. In case of periungual eczema, the picture depicts nail plate thinning with diffuse scaling associated with periungual inflammatory sign. In infection, we have superficial white onychomycosis, which is a classical example of nail fragility secondary to the nail plate damage. Other conditions like syphilis, pulmonary tuberculosis, leprosy, we are going to encounter brittle nail. The picture shows multiple white opaque friable spots on the nail surface. In systemic and the general condition, it is basically seen in the nutritional trace element amino acid deficiency condition. Medications like retinoids, antiretroviral, penicillamine condition. 90% of cases of hypothyroidism, we are going to have brittle nail. Other than that, in case of diabetes mellitus, peripheral vascular disease and collagen vascular disease. In case of amyloidosis, we are going to have onycholysis, longitudinal ridging, and the crumbling is seen. Moving ahead, traumas and the alteration of the nail hydration. With further repetitive microtrauma over the nail plate surface, this causes the nail fragility. Certain occupations are involved like housemaids, nurses, hairdressers. They have that increased risk of frequent wetting and drying. Solvents like chemical, detergents, they also disrupts the lipid and reduces the nail cohesion. Excess dryness followed by dehydration. This vicious cycle leads to the brittleness, splitting and the fractures. Cosmetics like nail polish, remover, artificial, as discussed before, contribute to the traumatic brittle nail. Nail fragility. This picture represents nail fragility due to mechanical trauma. In case of onychotilomania, the distal margin shows that the nail has an irregular, fragmented appearance with scaling. And in the second picture, this shows nail fragility due to multiple time prolonged use of nail lacquer causes yellowish discoloration and onychorexis, most marked in the distal part of the nail. Now we are going to discuss treatment part. Firstly, if the patient has secondary brittle nail, we have to treat the primary dermatological cause whenever identifiable. Next, over to this, core measures like we have to avoid the trauma to the nail, avoid irritants and allergens. We should also advise our patient to limit the use of water and detergents exposure. We should encourage the regular use of emollients. As we also know that the major cause of brittle nail is idiopathic. With this, we should supplement our patient biotin, vitamin B7, trace elements, amino acids, especially cysteine. What is the significance of biotin? As we all know, biotins improve the keratin biosynthesis, increases the intercellular cohesion of the nail plate. This, over the study, it also shows it increases the nail firmness, hardness with biotin supplementation. The dose which should give to our patient is 5 to 10 milligram per day for over 3 to 6 months. High dose should be avoided as it can seen in false laboratory result in case of thyroid, troponin, prolactin and the pregnancy test. We should give iron when we have ferritin less than 10 nanomilligram per ml. Zinc deficiency contributes to brittle nail, so we should give at the dose of 20 to 30 milligram zinc, which improves the fragility. Here are the few recent advances. Biomineral formulations like amino acid, vitamins and minerals that should be given for a duration of 3 months. Bioactive collagen peptides are also seen to increase the nail growth rate. Topical nail hardeners and lacquers that contains silicone, hyaluronic acid, HPCH, polyurethane that is FDA approved increases the nail strength and the barrier function. Certain protective measures should be followed like using cotton gloves under vinyl for wet work. Also, nail wrapping should be done in case of recalcitrant cases. Here are certain few points we should keep in our patient while dealing with the brittle nail case patient. Firstly, patient education is the cornerstone of the cure. Brittleness is a sign, not a diagnosis. We should go take the history and we should find out the exact cause, whether it is idiopathic or it is underlying due to secondary cause. Third, pathogenesis is mostly around the nail plate integrity. We should also focus on the adjuncting therapy like nail moisturizer, urea, formulations, hydroxypropyl chitosan lacquers. All these help increase their strength and the surface. Lastly, water is both friend and foe. Excess hydration followed by rapid dehydration causes microfractures within the nail plate and further leads to lamellar splitting. Thank you for patiently listening.
Thank you, ma'am. Thank you for nice. Any question from audience side? Thank you, ma'am.
Here we come to the end of this scientific program of 14th National Conference of Nail Society of India and ONYCHOCON 2025 at Land of Buddha. I thank you all the learned faculties who attended in this extreme weather and all the delegates, especially the PG students who have participated and come across part of India. And on behalf of scientific and organizing team, I thank you all for your active and continuous participation as well as support. Thank you all. Now I call for the valedictory function.
Dear all, so with this we come to the very last part of our conference today, so the valedictory function. May I kindly request NSI President Dr. S. Charan to come to the dais. Our immediate past President Dr. Vineet Rehlan, sir. Our Vice President Dr. Shikha Bansal, and our Joint Secretary Dr. Vishal Gaurav. I would also like to invite the core organizing committee, without whom this conference wouldn't have been such a success. Our chief patrons, Dr. P.K. Roy and Dr. M.K. Sinha. Our organizing secretary, Dr. Abhishek Kumar Jha, sir. Our scientific chairperson, Dr. Vikas Shankar, sir, and scientific secretary, Dr. Shwetarina Pradhan. And our conference treasurer, Dr. Punkesh and Dr. Rajneesh, sir. And our joint secretary, Dr. Shiparna Deb. And Dr. Shivani. May I kindly request our President, NSI President Dr. Charan, to say a few words.
Good afternoon to one and all. Dignitaries on the dais, Dr. Vineet Rehlan, immediate past President, Dr. Shikha Bansal, Vice President of NSI, Dr. Vishal Gaurav, Dr. Sujala, Secretary and Joint Secretaries, Dr. Abhishek Kumar Jha, the backbone of this conference, Dr. Vikas Shankar, Scientific Co-Chair, Dr. Shwetalina, Scientific Secretary, Dr. Punkesh, Dr. Sriparna and Dr. Shivani, and all the members of NSI in the audience and also the young postgraduates who have been a part of this conference. I'm sure all of you will agree with me that this conference was a grand success. I compliment the organizing team along with Kunja too. Grand success because of the following reasons. One is, in spite of a very short notice, they could pull off this conference in a manner in which we more than expected. We didn't expect that this will come up to this level. We're really happy. The whole NSI team is really happy with the way the conference was conducted. The venue was excellent, food was good, and more so, the scientific content was very, very informative and very up-to-date knowledge has been given to the postgraduate. That's one. What more does a postgraduate or a young dermatologist require from a conference? All those things have been presented here. I'm sure all of you will agree with me that Ram and Lakshman, I call them Ram and Lakshman, Abhishek Kumar Jha and Vikas Shankar have pulled off this conference in a way. I request all of you to give them a standing ovation, please. Thank you, thank you. I'm sure all of you would have jotted down a few take-home points from each of the lectures. There is a lot to learn. Every time you listen to some speaker, there will be something new to learn, and I'm sure these takeaway points will help you in treating your patients better, and that's what is the conferences and such programs are meant for. And I'm sure even the workshop that was organized on Thursday was also informative, and you must have, most of you must have got stimulated and decided to take up nail surgeries. You may not become totally a nail surgeon, but at least take up nail surgeries without hesitation in your future practice. Okay. With that, the purpose is served. I feel very satisfied as a president of Nail Society of India. I'm sure we are going in the right direction. Please patronize us. Please become members of NSI and encourage us. Thank you so much. And my wholehearted thanks to the entire team BIHAR once again. Thank you.
Thank you, sir. So without further ado, we'll move on to the prize distribution for various categories. So I'll start off with the poster presentation. So all of you delegates, I would like to announce that each of you can collect a copy of our NSI journal, Journal of Onychology and Nail Surgery, at the Cystopic stall. Please, each of you collect your copies. So for the poster, the third place winner is Dr. Nikhil Sharma. We have a memento now. I would request the winners to please come on the dais to collect your mementos. The second place goes to Dr. Shivani Kumari, AIIMS Patna. And the first place to Dr. Anvesha Mohana, UCMMC and GTB Hospital, New Delhi. Next is under the award paper category. The third place goes to Dr. Zoya Nasreen, AIIMS Patna. The second place to Dr. Rishabh Sanghvi, AIIMS Patna again. And the first place to Dr. Shruti Garg from VMMC and Safdarjung Hospital, New Delhi. Dr. Zoya's talk was on efficacy of infliximab in nail changes and of reactive arthritis, a retrospective observational study. Dr. Rishabh Sanghvi presented on nail changes in Hansen's disease in tertiary care hospital in eastern India, a retrospective record-based cross-sectional study. And Dr. Shruti Garg spoke about clinico-radiological assessment of 110 nail units in lichen planus. We next move on to the quiz category. The third place winners were AIIMS Patna, Dr. Mishkat Fatima and Dr. Sayan. Please come on to the dais. The second place winners were from PHCH, Dr. Patna, Dr. Jaya and Dr. Neha Nidhi. And the first place winners, AFMC Pune, Dr. Rashil and Dr. Diksha. Dr. Rahul and Dr. Diksha. With this, we move on to the NSI Awards. So we had our NSI Cystopic Thesis Award session where we had 2 presentations. The second place goes to Dr. Chayashri S. For the top, she presented on evaluation of clinical dermatoscopic and etiological features of melanonychia. And her guide supervisor is Dr. Shikha Bansal. May I request Dr. Chandragovar ma'am to also please kindly join us on the dais. I'll give it to you again for the research grant. Okay. And the first place goes to Dr. Tanveed Kaur Makkar, and she presented on the association of nail changes with peripheral arterial diseases in geriatric population. And her supervisor is Dr. Chandragovar ma'am. So Dr. Tanveed wins a cash prize of rupees 10,000. Next, we have the NSI Thesis Research Grant winners for the year 2024. May I call upon Dr. Anvesha Moharana for her thesis on efficacy of fractional carbon dioxide laser as an adjunct treatment for onychomycosis, an intra-individual off-label randomized controlled trial. and her supervisor is Dr. Chandra Govar. The next NSI Thesis Research Grant 2024 has been awarded to Dr. Shruti Garg for the topic, for the thesis, Clinico-Radiological Assessment of the Nail Unit in Lichen Planus. And her supervisor is Dr. Shikha Bansal. We now have the ONYCHOCON 2024 travel grant. So this is a travel grant being awarded to the winners of the NSI Cystopic Thesis Award session. So the current winners will receive the grant for the next year, and also the quiz winners. So here I would like to invite Dr. Jayant Tandi and Dr. Ananya Arya for having bagged the ONYCHOCON 2024 travel grant. So if you are here, kindly come on the dais. No, I think, okay. Yes, they were the last year quiz second place winners, and they're from AIIMS Nagpur.
So this time,
yes. Yes. So under the NSI Cystopic Thesis Award session, Dr. Chayashri and Dr. Tanveet will be eligible for the travel grant for the next year.
The ONYCHOCON travel grant is awarded to the first prize winners of the quiz, as well as the first prize winners of the award paper and the e-poster session for the next year. 4 maximum travel grants NSI gives.
So the winners, you should kindly contact myself, Dr. Sujala, to please pass on your contact details, your phone number and your email ID, so that we can communicate with you regarding the travel grant for the next year. So you will be awarded a complimentary registration, accommodation on sharing basis, and travel expenses also. So congratulations.
Two appreciation awards, Dr. Tanya and Dr. Subhashri for AIIMS. Their work.
Dr. Tanya and Dr. Subhashri. I'll announce that now also. We would also like to pass on 2 appreciation awards for our SRs from AIIMS Patna, Dr. Tanya and Dr. Subhashri, who have been of immense help in the background. Please come to the limelight.
One by one.
Congratulations on a job well done. I wanted a photo with your bag. Okay. डॉक्टर चावा का चेक अनाउंस कर दो.
Certificates of the quiz e-post.
So the poster presentation winners, the quiz winners, and the award paper winners, your certificates are available at the dais. Kindly collect them before you leave. Right? organizing team. We would now like to call our members of the organizing committee, Dr. Shivani Shekhar and Dr. Pallavi Kashyap. Please come on to the dais to receive your memento of appreciation. Dear delegates, with this we come up to the very fag end of our conference. I would like to invite a few of you to kindly share your experience and share a few words. If any of you are interested to say anything, please.
एनीवे हम तो दूसरी दुनिया में थे, पता चला। अच्छा, ये कॉन्फ्रेंस बहुत ही अच्छा रहा, बहुत इन्फॉर्मेटिव, खास करके हम लोगों के लिए जो हम लोग पेरिफेरी प्रैक्टिस करते हैं और हर चीज़ ना सुनने को मिलता है ना देखने को भी मिलता है, ना वैसा बुक्स है जिसमें इस तरह से एक ही जगह सारा चीज़ मिल जाए। तो उस हिसाब से ये कॉन्फ्रेंस बहुत ही ज्ञानवर्धक रहा, बहुत ही इन्फॉर्मेटिव रहा। थैंक यू। इसी तरह का कॉन्फ्रेंस आयोजन होता रहे तो हम लोग आएंगे, निश्चित आएंगे। थैंक यू।
Thank you, sir. Would anybody else want to share a few words? Yes, doctor, please.
बहुत ही ऑर्गेनाइज्ड कॉन्फ्रेंस था और इसमें साइंटिफिक सेशन बहुत ही अच्छा था और हम चाहेंगे कि इस तरह का और भी आयोजन होता रहे बाद में भी। थैंक यू फॉर ऑल ऑर्गेनाइजिंग कमेटी।
Doctor?
This conference was definitely worth all the trouble we went through to get here. I feel a lot of people here are already aware of the journey we took, but we are, as postgraduates, this was definitely an opportunity that we cherished, and it was totally worth it, whatever happened on the way here. Thank you so much.
Dr. Anupam?
Thank you for putting such a great show, Team ONYCHOCON 2025. Thank you for having me here. It was, of course, a wonderful learning experience. Doing the quiz prelims yesterday was fun because we had finished the prelims, but one more team came at the end. They were traveling by bus, I think a team from UCMS. Then the prelims was done. Another team came from, I think, Safdarjung. They were also traveling by bus. So this enthusiasm speaks a lot about the USP of the conference. Glad to be a part of this conference.
May I invite our organizing secretary, Dr. Abhishek Kumar Jha, to kindly share a few words.
Good afternoon, everyone. When this conference was given to me, this was after a long time we were doing a conference in Bihar, because you all know that we were doing most of the Bihar conferences outside. So I really expected that there will be less delegates coming to the conference, and I can see the hall on Sunday afternoon, so many people are here. So thank you, everyone. First of all, I would like to thank NSI for giving this opportunity, and all the delegates, all the PGs and the senior members coming far from other part of Bihar. Thank you so much. And again, I would like to thank the pharma companies who have stood behind me always in this conference also, and I hope in the leprosy conference also they will stand like this only. And I would like to invite you to the next LabCon, which is All India Conference Biennial, which will be held in AIIMS Patna from 27th, 28th of February and 1st March. I invite all the PGs also to send award papers. It's open. You can go to the IL website and you can apply for the award papers also. Again, thank you, Chandra ma'am, for coming. Thank you, everyone. Thank you so much.
I would request our scientific chairperson, Dr. Vikas Shankar sir, to kindly share a few words.
Thank you, Dr. Sujila. First, I would like to thank President NSI, Dr. Sachidanand sir, for giving us this beautiful opportunity. Initially, we thought how we can do, and then we decided, yes, we can do it. And there is a zeal to do it, a focus conference on nail. So I think it is well attended by all age groups, students, PG students, as well as the private practitioners and academicians. So it is a great moment for us. Yes, we have did it. And we got all the wholehearted support for the NSI, all the team sitting here. I want a big clap for them for giving us this opportunity. As well as I would like to request all the members present here, dermatologists present here, either PG or senior members, to become the member of NSI. For especially the Bihar PGs who are sitting here, there is a lot of opportunity, a lot of grants and a lot of awards that there. If you become the member of this society, you will part of it and you will know the information on the right time. So I request all the members, PG student also, to become the member, and all the senior members also to become a part of this society. It is a very focused society, and nail again, khujli se rahat hamesha nail se hi milega. Thank you so much.
And forms are available with Dr. Sujla. So if any one of you want, you can just ask her and you can get it done right away. We had just 3 new members today.
May I kindly request our scientific secretary, Dr. Shwetalina Pradhan, to kindly share a few words.
So, from the scientific team, I would like to thank all the faculties, delegates, and who have made, because of you only, the conference is successful, because for any conference, scientific is the backbone for the success. So, and the organizing chairperson, of course. And thank you to my team for helping me in each and every step, and specifically Dr. Abhishek Kumar Jha. And I also like to thank my team, AIIMS, and who is supporting me, residents, and faculties who had a lot of support for workshop and the entire conference. Thank you.
I would like to invite Joint Scientific Secretary Dr. Shiparna Deb to share a couple of words.
Thank you, ma'am. Actually, this conference was something that started very last moment, but I have seen Sir, Abhishek Sir, Shwetalina ma'am, Vikas Sir, they were the cornerstones guiding everyone how to go forward and make it a success. Last moment mistakes were there, and sirs have always guided, and Sachi sir and Sujala ma'am were always there throughout to tell us how to go forward. And even the PG participation that we have seen, even in the last moments, we are like, no, do that. And they have come forward and done excellent. In the quiz, we have seen awesome questions, and everyone were very cutthroat. Like, that shows the enthusiasm among the PGs as well, how much they were into this. So yeah, I will say, according to me at least, it was an awesome, wonderful conference. Thank you, everyone.
Of course, I have not named all, but if anybody else from the organizing committee would want to share a few words. I would like to invite Dr. Chandar ma'am to the dais. She wants to address the delegates.
Just wanted to share a few comments because this is the 14th ONYCHOCON and the 14th ONYCHOCON that I am attending right from the beginning when Dr. Sachidanand had held the first ONYCHOCON in Bangalore. From there, the journey has been a total roller coaster except for 2 ONYCHOCONs which we had virtually during the COVID years. Rest have been in various cities in India. So what I would like to say, out of my experience of all the 14 ONYCHOCONs, I can safely say that this one was really marvelous, really marvelous. And I say this on behalf of Dr. Archana and Dr. Sushil Taliani, our past presidents. Dr. Archana is our founding president, who could not be here today because of prior engagements. And the hard work that has been put in by the organizing team, Dr. Abhishek, Dr. Vikas, Dr. Shvetlina, the whole team of AIIMS Patna, Dr. Gaurav, and all the faculty members and all the postgraduate residents whom I saw standing on one foot during the workshop and doing everything, running from pillar to post to get everything done on time and in a proper manner. This is truly amazing. This shows the amount of camaraderie that you people have, and I'm sure you will do further conferences also with this zeal and will ace it again and again. Thank you so much for raising the bar so high.
I would like to invite all the organizing committee team members to the dais. Please come over here. We'll take a group photo. And along with the NSIEC, we'll do the organizing committee photo once, and then we'll take a photo with all the delegates. May I please invite Department of Dermatology from all the Patna medical colleges. Please come join us on the dais. The SRs, the postgraduates, please come join us. I'm sure each one of you have contributed immensely to make this conference a grand success.
Please join us behind and in front. This is Dr. Sachi's signature style. You'll always cherish this photo in years to come.
With this, I would definitely like to wholeheartedly thank once again the organizing chief patron, Dr. P.K. Roy, organizing chairperson, Dr. M.K. Sinha, our organizing secretary, Dr. Abhishek Kumar Jha, treasurer, Dr. Punkesh Kumar, joint organizing secretary, Dr. Rajneesh Kumar, the scientific committee, chairperson, Dr. Sudhanshu Singh, scientific co-chairperson, Dr. Vikas Shankar, scientific secretary, Dr. Shvetlina Pradhan, scientific joint secretaries, Dr. Shiparna Deb and Dr. Shivani Shekhar, and of course, all the members involved in making this conference a huge success. Thank you one and all. We request all the delegates to kindly join us. We can have some of you sit in front of the dais. Please come join us. All the faculty and delegates.
Paranoia.
Everyone kindly join for lunch.
Thank the event organizer and the pharma company people.
सर तो बोल दिए अभिषेक सर
Announce नहीं करना
सर सर
अभिषेक सर हो गया All right.